Good morning. My name is Alan Weil. I'm Editor-in-Chief of Health Affairs. We're thrilled to be here today to announce the release of the September 2018 issue on health and, this is the spring 1996 issue on health and healthcare in California. People ask why an issue on California, and the answer is 22 years seems like enough time to let go by between them. But in all seriousness, this is the September 2018 issue, California Leading the Way, a full thematic issue devoted entirely to topics of relevance to California. And it's a real privilege to be able to have this event here at RAND in California. When we do thematic issues, we tend to have a release event, usually at the National Press Club in Washington, D.C. And it's an opportunity for all of the authors to come together and present their work. And that's what we'll be doing today. It leads to a somewhat high-speed tour through a few hundred pages of very dense but also important information. The good news is in about a month, on October 15th, we'll have an event in Sacramento where we're able to step back a little bit and put some of this in a bit more of a policy context. And that's what we like to do at Health Affairs. On the one hand, we have an issue full of empirical work that really moves forward our understanding and knowledge of health policy. And then we'll also, as I say, have an event where we can place it a bit more in the current policy context and go beyond the words on the page and the words in the papers. It's that combination that makes this job fun. So we're able to do this issue with support from the California Healthcare Foundation, the Blue Shield of California Foundation, the Leonard Schaefer Center at USC, and the California Endowment. Very grateful for their support. I want to acknowledge Andy Bindman from UCSF, who was our theme advisor. You'll hear from him later. Jonathan Bohr on our editorial team, who led the editorial process for this issue. It takes a tremendous amount of work of many people to put this together. So just to lead us off, when we're putting together a theme issue, we try to cover a range of perspectives, and that's exactly what I believe we've done here and how we will structure the day today. We're an empirical journal, and we want people to understand what's happening, what people are trying, what works, even sometimes things that don't work. So we'll have a panel on a number of delivery system innovations that have been carried out in California and some of the research results from those. California has an interesting story around markets, consolidation, an issue that's true around the country, but some particular data and policies here in California that we'll focus on the second panel. California, of course, has been a leading state in trying to expand access, not just through coverage, but also through programs that expand the reach beyond the insurance card, and we have a number of papers that address that. And then we are bringing together some folks at the end of the morning to look towards the future. What are the issues that California will face moving ahead, particularly, of course, with the push towards various potential models for universal coverage, as well as looking at the racial and ethnic changes that are happening around the country, and California having some of those, being a leader in those trends, and therefore lessons for the rest of the country. So just as I close my very brief opening remarks, do want to note that when we were thinking about the issue, what we felt was important was that on the one hand, it be of value and interest to Californians. This is your story, a place to tell the story, a place to deepen your own understanding of the story. But it's also important that it be of value to people not in California. And I think the title, California Leading the Way, with that tantalizing question mark at the end, is to have people understand that there are things to learn from California. In some instances, we see California out ahead and other states following. In other places, we're not sure whether other states or the country will follow. So this is designed both to support your own thinking and analysis in California, as well as to help the rest of the country learn from California. And it's that pairing that we've tried to accomplish in the issue and that we are excited to be able to present today. So the format today, It's going to be a lot of fairly rapid-fire presentations of papers. We, of course, hope that you've read the issue cover to cover, but if you haven't had the opportunity, this will be the fastest way to learn what is in the issue. The final session will be a bit more conversational because by the time lunch rolls around, you'll be tired of 7-minute PowerPoint presentations. That's our plan for the day. Before we move into the authors, we're going to have remarks from Secretary Wilkening, but in order to introduce him, I want to offer thanks and appreciation and a moment for comments from the CEOs of the two foundations that really made this issue possible. The leadership role for this was from the California Healthcare Foundation, Sandra Hernández, President and CEO, who prior to being at CHCF was at the San Francisco Foundation, and we met many years ago on the President's Commission on Consumer Protection and Quality in the Healthcare Industry, appointed by then President Bill Clinton. And so I've had the pleasure of knowing Sandra for a good long time. We don't talk about how long. Peter Long, I've also known for a good long time, President and CEO of the Blue Shield of California Foundation, a number of roles prior to that at the Henry J. Kaiser Family Foundation, the California Endowment. You all know the two of them well, so enough of my remarks. I'll turn it to the two of you to introduce the secretary, and then we'll move into the program for the day. Sandra, Peter.
Thank you, Alan. Good morning, everybody. Well, we're very excited about this issue at this moment in time. Alan asked, does California portend the future for the country? And I don't know the answer to that, but I think what this issue, what you'll hear about today, is about how important healthcare is in California, what we've learned, what's worked. It's a very innovative state. What have the innovations shown? And of course, we also hope that it will do what we believe is really important, which is to use evidence and to use data and to really make sure that it helps inform where we're going in the future. The opportunity to reflect on what's worked well and what hasn't is unique in California. Just about everybody in this room is thinking about what's possible and going forward. And so we think for the 40 million people who live in the state, for the 500,000 children who are born in California every year, that, looking at maternity, looking at the Medi population, really understanding the innovation that's happening in our delivery system, understanding what our health plans are doing, and importantly, to inform a policy debate as we move into a new administration. We think the timing could not be better. So with that, Peter, I know you want to make a couple remarks, and then we'll do a few thank yous.
Great. Thanks, Sandra. Welcome, everyone. We're thrilled to be here with you today to share this issue. It's an exciting time. And I think oftentimes in healthcare, we think the healthcare system is much simpler than it is. And whether it's a health system or health non-system, it is incredibly complex. And they say you actually don't know what's happening in a complex system until after it's over, right? And you can only look back at the patterns and describe, oh, that's what was going on. That's really what was happening underneath the surface. And to me, this issue is really about that, is what are those patterns that we see emerging across the last decade or the last 22 years since the last time we had an in-depth look here in California. The second thing they talk about in complexity is experimentation. And what I think being in this room with all of you and all of the tremendous talent we have in California, we are constantly experimenting on our system. For better or for worse, we are constantly experimenting, and it wouldn't work if not for all the researchers, academics, and others in this room who actually tell us, did that experiment work? And if not, why didn't it work, or why did it work? So to me, this is the culmination, and it's a wonderful reflection of kind of who we are as Californians, taking on the experimentation, and then hopefully, honestly, with integrity, sharing with the rest of the country kind of what happened and what we have to share with you. So thanks very much for being here, and we look forward to the conversation.
I think Blue Shield and the health foundations in the state all recognize what an incredible resource health affairs is. As Peter mentioned, it really is the rigor that pulls together in a very scientific and with a lot of integrity, and really that doesn't happen without extraordinary leadership and talent at health affairs. And so I want to acknowledge Alan and your leadership and your entire team. Thank you for being open to doing this. and for undertaking it with the incredible enthusiasm and partnership that you've done that. I also want to thank his team, Jonathan Bohr, Debbie Boylan, Jane Hibbert-White, Kelly Whalen, and Sue Duquette. And of course, Andy Bindman, who's a colleague and a friend and who was an advisor on this particular issue. Really, it's been an incredible effort by an entire team. And so on behalf of the foundations, both of us, we want to thank Health Affairs, their leadership, and the editorial work that was done to put this together.
And thanks to the funders, our fellow funders, the California Endowment and the Leonard Schaefer Center at USC. It takes resources to do this and to be committed to telling the truth and to telling these stories. So thank you to our funders, not just for supporting this issue and to the California Healthcare Foundation, but for the work that you're doing every day to fund some of this work and to fund the knowledge seeking that we're celebrating here today. And also thank you to the RAND Corporation. I think RAND, no better place for a deep inquiry and for a deep sharing than the RAND Corporation, whether about healthcare or any topic for that matter. So thank you to RAND for graciously hosting us today. So I'd like to just take a moment and introduce our secretary, the Secretary of the Health and Human Services Agency for California, Mike Wilkening. He is well known, although he is relatively new as the secretary, he is well known to many of us in this room. And I think his passion has been around open data and transparency and bringing information and data, which really is the fuel to the healthcare system and to the health system more broadly and health of Californians. And Mike has been a champion of that for the last decade, tenaciously trying to open up our data, make it available, bring it out to the world so that all of us and others not in this room can use it to improve the health of Californians. And it's an incredibly laudable crusade I think you've been on for the last decade. And as secretary, he's leading us by being the chair of Covered California. So he is an expert on a range of all issues from access and coverage to health data and quality. And it's a great pleasure to introduce to you Secretary Mike Wilkening.
Welcome, Michael.
Well, thank you for that introduction, Peter. I'll hope to live up to it. And thank you all for having me here today. Again, I'm Mike Wilkening, Secretary of the California Health and Human Services Agency. I would like to start out by saying that while I didn't read every single word in the issue, I did read most of it, and there's just some fascinating articles in there, some real insightful analysis that's been done, and I think really a good foundation for a lot of the discussions that we have to have moving forward. So I think, you know, the health affairs issue is, you've done a great job gathering the analyses that we need on our efforts to achieve universal coverage and the discussions around single payer, what the impacts of the ACA have been to this point, various localized efforts to improve aspects of the healthcare system, and the overall state of the healthcare system and the health of Californians in general. I think that what that allows us is to see how far we've come, where the efforts have not resulted in the change that we anticipated, which I think is just as important as figuring out which ones actually have worked and pushed us forward, and the potential for additional changes. So the Brown administration over the last 7.5 years has shepherded through an amazing change in the healthcare system. Among those, we've worked on increasing coverage. So we brought up the first ACA compliant exchange in the nation. We expanded Medi-Cal to cover childless adults. We expanded Medi-Cal to cover undocumented kids. And as a result, we have over 13 million people in Medi-Cal now, approximately a third of the state's population. We also have almost 1.5 million more people who are receiving insurance through Covered California. And the uninsured rate is an historic low of less than 7%. And that's compared to down from 17% in 2013. So we've seen a 10 percentage point drop in California, which is the largest in the nation. We've also had a series of targeted rate increases and supplemental payments for Medi-Cal, so making sure that we're targeting in the resources that we have available and not doing just across the boards, but really figuring out where we can have the most impact with the resources that we have available. And these were put in place in a very informed manner as we were trying to bring things back up after the Great Recession. So when this administration came in,
We're in the process of cutting Medi-Cal, taking away optional benefits, reducing population, and as we've built the program back up, we've done that in a very targeted manner. We've also been working on integration of services. So CalMediConnect, and Sandra was talking about the Medi-Medis, so the dual eligibles, working on bringing a pilot program up for managed care for dual eligibles, and really figuring out how to coordinate care for that population. And then also the whole person care pilots. And I think that these are really the future. So the whole person care pilots is where we're integrating health, behavioral health, and social services, especially as it relates to homeless populations. And so I do think that this is the future that we need to be thinking of, that if we want to talk about health, we need to be talking about the social determinants as well, not just about healthcare. Healthcare is what you have once the system's broken down for you. You have a condition that needs to be ameliorated, then you're in the healthcare system. If we want to talk about health, we need to talk about how to keep people out of healthcare. And if you want to talk about how to reduce costs, you really do have to think about things that are upstream rather than talking about how to deal with populations once they're in the healthcare system. The last budget included the formation of a council on healthcare delivery systems that's going to be responsible for researching and providing options for unified public financing to achieve universal healthcare. It's obviously a subject that's going to be talked about a lot today. It's that council will come up in the next administration. I do think that we're at a pivotal moment. So we have a transition of governors that will happen at the beginning of the calendar year. We have continued pressure at the federal levels to erode or ultimately repeal the Affordable Care Act. We have continued attempts to fundamentally restructure both the Medicaid expansion and the underlying Medicaid program. And we have an increasing demand for single-payer system. So I think that the issue of health affairs that we're all talking about today and the conversations that we're going to have here today and that we'll have in October in Sacramento provide important information and analyses that policymakers are going to need to figure out how to move the system forward and what the next steps are. So I'm looking forward to a very engaged conversation today. Thank you.
It's a terrific overview and introduction for the day. So it's my pleasure to introduce those who will be presenting on the first panel, which is focused on delivery system innovation. Just because you're a little exposed up here, we're going to have our presenters stay down here and come up one at a time, and then we'll all join for a brief period of discussion after all of the presentations are done. We're going to hear from Carrie Graham, Associate Adjunct Professor at the UCSF Institute for Health and Aging, with a joint faculty appointment at UC Berkeley School of Public Health. Christine Thorne, the Medical Director of Be There San Diego in the School of Medicine at UC San Diego. Christine is also a primary care physician at UC San Diego Health. Todd Gilmer, Professor of Health Economics and Vice Chair for Faculty Affairs, Chief of Division of Health Policy in the Department of Family Medicine and Public Health at UC San Diego. And Elliott Main, Professor of Obstetrics and Gynecology at Stanford University. I'll turn it first to Carrie to kick us off today.
Here we go.
And, oops, this is for you.
All right. Oh, here we go. Start. Hi, thanks for having me here. I'm here to talk today about our article, Beneficiaries Respond to California's Program to Integrate Medicare, Medicaid, and Long-Term Services. And this is essentially a paper that describes part of our evaluation of CalMediConnect. And I'm going to try to talk about, I'm going to try to talk about 3.5 years of work in 5 minutes, so here we go. It's good exercise. So we spent about 3.5 years evaluating California's dual financial alignment demonstration. California was one of 12 states to implement one of these demonstrations, and as California always does, ours was the biggest. What we did was use the already well-developed Medi-Cal managed care system that we have in California in 7 counties, and those health plans in those counties developed a new product called CalMediConnect. that integrated Medicare, Medicaid, and long-term services and supports, including nursing home services, adult day health care, and to a certain extent, California's program called In-Home Supportive Services, which is the Medi-Cal Home Care Program. It started in 2014, and by 2018, we have over 100,000 people enrolled in our demonstration. Compare this to New York's demonstration, I think there are about 10,000 people. About half opted out. We thought there'd be a lot more people in the program, but the federal rules prevent you from mandating people into Medicare HMOs, so people opted out. Usually because they had a Medicare doctor who they wanted to stay with, who wasn't in the plan's network. They had a few extra benefits when people enrolled in these programs. There was a new care coordination benefit, so these plans scrambled to put together new care coordination units. They did interdisciplinary care teams, they did health risk assessments, and they also provided other sorts of benefits like non-emergency transportation. We did a lot of things in this evaluation, focus groups, key informant interviews, but our paper is on our telephone survey with beneficiaries. This is not a pre-post test. We followed people post-enrollment. We surveyed over 700 beneficiaries in CalMedi Connect. They had been in the program about 6 months, and then followed up with them a year later in 2017. We also had a control group of people in non-demonstration counties. And we looked at all different domains, from primary care, specialty care, durable medical equipment, prescription medication. And in all those areas, we asked beneficiaries themselves questions about their access, their utilization, their unmet needs. The paper looks at the data in a couple ways. First, we compared beneficiaries at time 2. That was our most mature time point, and looked for any differences between the experiences of beneficiaries at that time. We saw that CalMedi Connect enrollees were less likely to have problems with prescription access. They were more likely to get all the help they need with personal care, which was a big finding because unmet needs for personal care are really high among the duals population in California, and I assume everywhere. And there was no differences in care coordination, which we found funny because it's the Coordinated Care Initiative. We also looked at the CalMedi Connect folks, just paired analysis over time, T1, T2, because there's a lot of evidence to suggest that, anytime you enroll, especially people with disabilities in managed care, they're going to have some problems, but also adjust over time. So we wanted to look at that. We did see there was pretty high general satisfaction and ratings of quality of care were high at T1, and they got higher at T2. More people increased those than decreased. 60% of the people who at T1 had in-home supportive services had an increase in hours. And we think that that's because of the CalMedi Connect's plans and their care coordinators' involvement with the IHSS program. Unfortunately, that involvement is no longer going to be paid for. So we're interested to see how much, the structure of that system maintains when the funding goes away. We did see a self-reported decrease in hospitalizations and ER visits, which needs to be confirmed by claims, but that's an interesting finding. And again, we saw no changes in unmet needs for care coordination over time for those in CalMedi Connect. So, gosh, that was 5 minutes. We were working really closely with an advisory group. We worked really closely with Department of Healthcare Services. There were some policy changes that were informed by this evaluation. I think the one I'm most proud of is that the Department of Healthcare Services is now requiring plans to ask about LTSS. The health risk assessments ask things like, are you overweight? Do you smoke? And now they're going to ask about unmet needs for LTSS. So I think that's a great change. And there's also going to be a new CHIS module that many of you probably heard about that's also going to ask about LTSS needs of Californians. So that's it.
Good morning, I'm Dr. Christine Thorne, and I'm here to speak to you about 1 in 5 fewer heart attacks, impact savings and sustainability in San Diego County Collaborative. Before I get started, I wanted to thank our lead author on this paper, Dr. Alan Fremont. Without his dedication and tireless support, Be There San Diego would not be where it is today, and We appreciate you greatly. So just to take a few minutes to tell you about Be There San Diego, we operate throughout San Diego County on a population of about 3.3 million people. We have about 2/3 of those patients in our healthcare systems that participate in Be There. We work on health team activation, healthcare system activation, and community activation, and then linking those together. Our healthcare team activation and healthcare system activation focusing around making sure that patients receive the optimal care that they need from their clinicians in order to prevent heart attacks and strokes for those who are at risk. Our community efforts focus around finding San Diegans who are at risk and providing them with the education and support that they need in order to take control of their health and link to clinical services appropriate for prevention of cardiovascular disease adverse events. All of our work is grounded in commitment to health equity and working across a broad patient population. We employ collaborative approaches to achieve our goals, and we specifically focus on efforts around hyperlipidemia, hypertension, and diabetes. At the start of Be There San Diego, the Right Care Initiative founded us, and they submitted an NIH grant proposing that improving control of LDL, hemoglobin A1C, and blood pressure in hypertensives would lead to a decrease in acute myocardial infarctions. We set out to evaluate whether this is true and build on a paper from Brett Fulton. We did a differences in differences analysis, which allowed us to control for differences in the rates in San Diego and California before the development of Be There San Diego. Be There San Diego came out of the Right Care Initiative in 2010, and looking at the early post-Be There San Diego period between 2010 and 2014, we saw a 22% decrease in acute MIs over this time period, compared to the rest of California, which saw an 8% decrease in acute MIs. We then looked to see whether this was sustainable over the long period, and although both experienced an uptick in acute MI after 2014, the difference was maintained, and the rate difference was 30 acute MIs per 100,000 residents, lower in San Diego. We then looked at calculating how many heart attacks we think were prevented by this rate change. In San Diego County, we estimated what we would have expected had we not seen that drop and had our drop only mirrored the 8% California drop. We calculate that we avoided 3,826 acute MIs and saved $85.8 million in healthcare costs between 2011 and 2016. We then turned around and estimated and predicted what would have happened if a similar collaborative had been used throughout California and similar rate reductions had occurred throughout the state. We predict that potentially avoidable acute MIs in California would have been 41,706 fewer MIs had California's rates matched those of San Diego's. And this could have avoided close to $1 billion in healthcare costs over the 6 years of this effort. We think that this effort was successful because of the unique nature of our collaborative. We've had the full participation of all of the health systems within San Diego and the FQHCs within our county. Their participation brings together people that are in the marketplace competitors. They compete for the same patients, but we've brought them together and use that competition in a positive way. They now collaborate with one another and compete for who can achieve the best quality outcomes. They share around a table real-time data on their quarterly quality metrics in an unblinded and transparent manner. They set goals for themselves of what they want to achieve, and they generally talk pretty frankly about what's worked, what hasn't, what challenges they've encountered, and what they plan to do to achieve their goals. While we cannot determine causation with this analysis, we are optimistic that the original hypothesis put forward at the foundation of the Right Care Initiative is met by these metrics and this analysis, and we are hopeful that continued efforts both in San Diego and similar efforts throughout California and the country could lead to similar results. Thank you very much.
Hi, I'm delighted to be here. Today I'm going to talk about our evaluation of the Behavioral Health Integration and Complex Care Initiative. The BHI CCI was implemented by the Inland Empire Health Plan, a large Medi-Cal managed care plan in San Bernardino and Riverside counties. IHP has over 1 million members, which is, I guess, over 1/13 of the Medi-Cal population, a network of 4,000 providers. In 2014, they saw a surge of 350,000 new enrollees under the Affordable Care Act. IHP leadership recognized that many of the enrollees faced barriers in access to care due to a shortage of primary care and specialist providers in this county. Also, as in all California counties, funding for behavioral health and physical health are separated and siloed at the state level. And that often results in fragmentation, lack of coordination at the county level. So the goal of the CCI was to improve integration of care and care management for the most complex patients. It was implemented in a variety of settings, including federally qualified health centers, multi-specialty clinics, behavioral health clinics. The core of the BHI CCI model was a care manager who would listen patient goals and incorporate them into shared care plans, behavioral health, a clinician who would provide evidence-based treatment such as patient activation and problem-solving therapy, and a care coordinator who would manage screenings and coordinate appointments across multiple providers. This was supplemented by practice coaching. Practice coaches would provide individualized feedback and support and implementing the necessary practice changes across these organizations, focusing on team empowerment, patient-centered learning, and implementation of quality improvement methods. Our evaluation of the initiative focused on the triple aim. So we were interested in whether the model improved quality of care and patient satisfaction and reduced costs. So as of April of this year, almost 7,000 individuals had enrolled in the BHI CCI. We looked at clinical outcomes pre-post among a group that had been enrolled in the initiative for 6 months, which is what we thought was needed to see clinical improvements. And we looked at cost outcomes pre and post enrollment here with the propensity scored match control group of IHP members who had enrolled, who hadn't enrolled in the BHCCI but had similar demographic and clinical characteristics as the participants. And then we looked at patient experience using focus groups. We had 6 focus groups focusing on the care experience with 2 of them in Spanish. With respect to clinical outcomes, we saw, I think, fairly high rates of screening for common chronic conditions such as depression, high blood pressure, and BMI. Not quite as high rates of screening for diabetes using A1C. Among those that exceeded the clinical threshold at baseline, the highest percentages were for depression and BMI. I think fairly high rates of screening at follow-up for those that exceeded the clinical thresholds, and then some statistically significant and meaningful improvements in blood pressure, depression, and an A1C among those that were above goals at baseline. We saw some differences in cost across these models. A large improvement in inpatient expenditures among those who were enrolled in the multi-specialty groups, and then some increase in outpatient costs among those in the FQHCs. So these include all encounters and claims, and among these organizations, kind of from both our analyses of the data and our conversations with patients during site visits. We believe that in the multi-specialty clinics, we're smaller with a higher, more severely ill, more complex population. It was easier for providers to identify complex patients that would benefit from the intensive case management. Whereas in the FQHCs, with a much larger population and fewer complex care patients, it was harder to identify those that might benefit from it. Nevertheless, kind of across these models, according to focus groups, the model was very well received. The primary theme from these was the patient voice. So the patients felt that their voices were heard, that their goals were incorporated in their care plans. The patients also noticed improvements in coordination of care and communication across providers. And then a subset of patients got very excited about being more involved in their care and wanted quarterly meetings with their teams of providers and things like that. So overall, I think it was very well received from the patient satisfaction. Kind of a main focus on this initiative by IHP leadership has been on sustainability. So the model was designed to prepare these organizations for case rate funding under health homes. I think in that sense, in kind of our experience with this project, instead of being seen as more of a point-in-time evaluation, we see this really as a new strategic partnership, a model for partnership between a health plan, its providers, and its members. And it's, I think, a partnership that's a bit visionary on changes in funding to support value-based care. Also, in that sense, it's a bit dependent on kind of health reform efforts and funding streams to support these models. Thank you.
Good morning. My job is to summarize 10 years of work in 5 minutes. Okay. And I had the honor of leading the California Maternal Quality Care Collaborative, and we're going to summarize our strategies used to address a variety of maternal issues at scale. How do you scale up for a state that has 500,000 births, as Sandra pointed out? So we identified 4 key steps that we want to discuss briefly here today. One is to use public health data to galvanize action. It's always hard to get off the ball to begin with. A key is to mobilize as many partners as you can think of, and we're going to describe a broad range that we use here in California. But really a key is to have access to rapid cycle data that you can feed back to hospitals, and that's been a key for all of our quality improvement projects. And lastly, one project is not enough. We've done a whole series of projects that I think additively impact the outcomes that we'll see. So California has 1/8 of all the births in the United States, 240 maternity hospitals. We saw the State Department of Health saw in 2006 a rise in maternal mortality that paralleled the United States, doubled in California and the US. We started the first maternal mortality review committee at that time, focused on quality improvement. CMQCC, our quality improvement arm, was started then as well. And over the next 5 years, we instituted a series of toolkits and quality improvement projects that was associated with a major decline in maternal mortality in California, not seen in the rest of the US. I guess required disclaimer is that the colors of these lines do not reflect my personal feelings about the politics of the state or the nation. We also were able to see significant declines in maternal morbidities, major complications in a before and after trial that was published separately. And currently our major project is reducing primary C-section, which is also leading to some major changes statewide. Stakeholders have been our key here. This has been a joint effort from the beginning between public and private partners. Many different agencies and departments within the State Department of Health have been engaged, as well as professional groups in every hospital system, not only the major private hospitals, but also the Kaisers, north and south. Consumer groups and hospital associations and other membership groups each have brought significant advantages to the table here. Our data system, has been a key element here. With partnership with the Department of Public Health and their vital records section, we were able to access each and every month, every birth certificate and every birth in California, 45 days after the end of the month, de-identified, and link that to hospital discharge diagnosis files provided by the hospitals now for 96% of the births. And alternatively, every year we get a file from Hotspot to fill in any missing pieces. So this is a very powerful set for benchmarking, for calculating in a web-based portal for every hospital in the state to see 40-odd statistics and comparison data, and as a base for quality improvement work. We took the lessons learned in the quality in the maternal mortality reviews and turned those into action steps in a series of toolkits. This is the hemorrhage one, our first one. There's also one on preeclampsia or hypertension, and one on cardiovascular disease, and lastly one on reducing primary C-sections. These have been very, very popular, downloaded over 10,000 times, not only in California, but throughout the country. As I mentioned, we've done a whole series of quality improvement projects, both public release of information like maternal mortality data in toolkits and our state reports, as well as actual on-the-ground collaboratives based on IHI principles within, with first 30 and then 40 hospitals at a time, and the last one was 130 hospitals at a time, again with many partners, including the Hospital Association, through the Hospital Engagement Network, as well as then other partners through here. At the same time, we've done a lot of transparency work, releasing data with the prior Secretary of Health giving annual reports and awards to hospitals that lowered C-section rates, for example. And we've been able to be transparent with C-section rates with a number of partners, including Yelp. So it's available. California hospitals are now available to have 4 of their key items available to everyone via Yelp. I would have to say, though, at this point, we get an incomplete. A very disturbing problem is the outcomes of black women in the United States and in California. Black women are the top line in this flow chart, and the solid line at the bottom is white women. Black women comprise 5.5% of births in California, but 20% of the maternal deaths. Okay. We saw a 50% decline in mortality in both black and white women, but the disparity between black and white women remains at 3 to 4 times. This is an area we hope to directly address in the next years, using those 4 same principles that I described earlier, with a heavy emphasis on community engagement. Thank you.
Yeah. You all were so good on time. We have some time for a few questions, and please come on. Expose yourself to the I'll just kick off with a couple of questions, and then we definitely want to get questions from you here as well. Carrie, if I can start with you, the overall picture on the duals is pretty good, given a lot of the concerns about disruption associated with the demonstration. At least that's part of what kept the numbers low around the country. Whenever we're doing something like this with a complex population, there's the difference between sort of the average responses, which are pretty positive, but the potential that there's a smaller number that are negative, but the experience of those negative could be quite problematic. So I wonder if you could just comment on not just the average, but a bit of the distribution and what some of the downside risk was associated with the intervention.
Absolutely. So, you know, when we look at the fact that 80% of people are very or somewhat satisfied with CalMediConnect, that still leaves 20% who aren't. We see 1 in 5 people who are in these programs are still experiencing disruptions in care, you know, a few years in. So that's really a lot. So we have done some analysis to look at who those people are, and across the board, negative outcomes are more common in people with disabilities, people with high LTSS needs. We're also seeing some patterns around access to durable medical equipment and supplies that are still, you know, really nagging at people many years in. So I'd say that's
So those
the
are things
biggest
to
problem
learn
we're
from.
facing. Absolutely.
Christine and Todd, I want to ask you a variant on the same question. Actually, Elliott, it came up at the end of yours as well. Christine, when you began, you presented a model of team, system, and community. Todd, at the end, you talked about plan, provider, member. These have something in common. Elliott, at the very end, you talked about community engagement. So I wonder if I could get at least the two of you, and maybe all three of you, talk a little bit about the relationships across those three parties. Those are not three that always work well together or that have much of a foundation for working together. And given that the structure had such commonality between at least the two of you, I'd just like to have you expand a bit on that. Christine, can you start with that?
Yeah, I think that the commonality in those things is really centered around the patient. And, we know, we're talking about implementing things we know are of value already. And just like everything else in our life, even if we know what we should be doing, actually making it happen is the trick. And so the same way you look to make sure that if you want to eat a healthy meal, that you have greens in your fridge, you have to have greens at the grocery store, you have to then bring them home and actually prep your lunch for the next day and take it. Looking at implementing quality improvement involves connecting with the patient and making sure they're aware of the needs and are willing to engage in their health care and address their hypertension, which isn't always their top priority, to talk with the physicians and make sure they're aware, because very rarely do patients come in complaining about their hypertension unless it's symptomatic. They come in with knee complaints or other things, and it takes effort to address what we know we should be doing. And then structuring the healthcare system and the healthcare team to provide that support to the clinician to address those variables. We see that kind of as all parts of a whole.
Todd?
Great. I think kind of echoing some of Christine's comments. As far as launching the initiative, a large part of it was due to the CEO of Inland Empire Health Plan, Bradley Gilbert, who had a large vision that he helped make a shared vision across the various organizations to improve care for the complex population. I think within that it was kind of engaging various levels of the leadership, both at the top and the middle leadership, and kind of addressing that goal. And then recognizing and addressing the kind of various barriers that are between these groups. So although you have the health plan that's paying for the services, the providers are largely independent, and in the past haven't been as concerned what happens in one setting for the another. So I think it was kind of communicating this vision of shared responsibility across the providers, which everyone pretty much agreed with, but in the past weren't motivated enough to address. So certainly the financial support provided by IHP kind of helped in part make that possible to allow providers to kind of address these things across multiple settings.
So I'd also add, maternity care is a little bit different than other types of medical care because women are healthy by and large, and they're not going to care for a disease. And that really requires a lot more solicitation of patients, of women's desires and goals. And that's something that hasn't been honored as much as we'd like to see in obstetric care. It's honored more in midwifery care, and we're trying to make obstetrics more like midwifery in some of these areas. I think we're also being informed quite handily by the recent Listening to Mothers survey that California Healthcare Foundation just launched last week, or just released last week, which is a great opportunity to spread around what we've learned from all kinds of Californians. We're working with a variety of community groups as well, so it's really a combination of working with patients directly as well as with community groups, particularly for communities of color that have, as you've seen in our data, in many areas have similar types of disparate outcomes that we need to address.
Great. Let me open it up to you all. We have microphones, so we'll ask you to identify yourself Don't be shy. I can keep asking questions, but this is a unique opportunity, so I hope you will take me up on it. Here we go.
Thanks for being here today. My name is Gene Dorio. I'm a physician from Santa Clarita, California. I've been doing house call there for 30 years, and I'm wondering with Dr. Thorne what the impact might be if we were to have physicians, physician's assistants, nurse practitioners go out to the home and not only see patients who might be potentially have heart attacks, but also those who were post-operative, maybe had a stent put in, those who have had strokes, and seeing whether there is impact there. Can we extrapolate some of the studies that you're doing right now and bring that forward and use house calls, which is a lot. Doing that, I can tell you that, you know, we get paid well to do house calls, but it's not $1 billion. So something different for us to think about in the future, maybe in San Diego.
Yeah, that's an interesting idea. I don't get paid $1 billion either. You know, I don't know exactly the impact that model would have. Certainly there's some really interesting data on the value of house calls and how that lends to our understanding of the patient's home care environment and kind of what else is going on in their lives and allows us to have a broader impact. I think, you know, at this point, we would like to be in a better position to enable patients to really do some things at home and have that count in the clinic and start extending from the clinic outwards with things like self-measured blood pressure monitoring, which is actually quite difficult to put in place. You mentioned DME, and there's a lot of barriers to that, and I think kind of pushing and connecting the clinic and home could be really useful.
Here's Debbie.
Thank you. Hi, Anna Gorman. I'm a reporter at Kaiser Health News, part of the Kaiser Family Foundation. Dr. Gilmer, you talked about sustainability. Obviously, some of these pilot programs aren't always sustainable or are not always scaled up. So what are some of the challenges to making that happen? And perhaps Dr. Main, you can weigh in a little bit on that, because this project on maternal quality and care has been going on for, like you say, a decade. So what lessons can we learn from that?
Sure. Probably two main things as far as sustainability, which would be kind of a continuation of the effort and the mission. I know IHP hired some of the consultants that implemented the model to develop new departments in the organization focused on integration and patient-centeredness. They're developing their own team of practice coaches to push it out to more organizations, and also developing community health workers to do some home visits. So they're kind of continuing to put effort into this. And then on the funding side, they're really aiming for the health homes initiatives under Medi-Cal. So they want to reorient these organizations to be able to receive funding under this initiative to kind of continue to support these efforts.
It's long been said in quality improvement that the biggest barrier to sustainability is the next quality improvement project. You take your eye off the ball and move on to the next ball. And so we're trying to get around that by working with data, keeping it live, having continual release from the state for the vital record data, as we were describing in the state reports, but also having alerts in our data center for if your complications from hemorrhage start to rise, there's notification of the hospital, and we're continually doing quality improvement projects again and again and again, so it's always first and foremost. I'd have to say, though, that the biggest source of sustainability is working with our health plans. And we're building incentives for some of the quality measures into not only the Joint Commission measure set, but also the financial incentives for quality that are in a number of the health plans, both Inland Empire, for example, partnership for the managed Medicaid plans, and several others, as well as the commercial plans. That, shall we say, keeps hospital CEOs focused.
Cheryl Danberg-Grand. Elliott, good to see you again. I was curious, the last graphic you had up with the racial differences, I wonder if you have any insights, speaking of your next journey in the quality improvement space, what do you think some of the factors are that are driving those differentials, and where might you focus some of your quality improvement efforts?
Sure. California is a very racially diverse state, as everyone in the room knows. Half our births are actually to Latinas. They actually do pretty well in California, most of the birth outcome studies. Native Americans do not do very well, but they're a very small proportion of our population. African Americans are clearly the ones who are most disadvantaged. I think at the end of the day, they're treated differently by the healthcare system. There are social determinants, of course, but there's other folks that have social determinants that don't do as poorly in maternity care as African Americans do. In our work with community groups and a lot of interviews, right now there's clearly a lack of trust between black women in the health system, particularly black women in maternity care. And that's something we have to overcome. It's treating women with respect and dignity and working with them so they're heard. I mean, this has been in the news a lot in the last year, from Serena Williams to CDC researchers to all kinds of folks who are clearly not being heard and not being treated well. So that's a fundamental change that we need to bring about.
Hi, I'm Chloe Bird, also at RAND. I really appreciate the paper on looking at maternity outcomes, but women's health isn't limited to female-specific problems. So I'm interested in the extent to which you've looked at what's working for men. Is it working for women? And where things are not working, is it really the same thing for men and women, given both biological and socioeconomic differences? And this may be playing out in the racial ethnic minorities as well.
So I can go ahead and address that. We did look at all age bands and separated out our analysis by sex and found similar decreases in both. I can also tell you from our internal hypertension control data, looking at about 210,000 patients, we do see similar rates for men and women. We've also looked at it across payer and see improvement across all payers in our system, and we're starting to look at race ethnicity, but because we get our data from health systems, that's a relatively new thing, and we don't have clear data on that yet.
Yeah, we haven't actually broken down our data by race, ethnicity, or gender. I mean, we did have 60% female in the data. For those that enrolled in the study, had an average of 4 or 5, major chronic conditions. I'm not sure if most of those were gender specific, but it's definitely worth looking into.
So I'm going to ask a quick last question. The only topic that comes up as often as sustainability is scale. And 2 of you have sort of regionally bounded initiatives. And then, of course, the question is, can those outside of California also learn from those that are statewide? I wonder if each of you could just quickly reflect on what you think it would take to scale what in all instances seem to be some pretty promising practices. Just go straight down the line.
Okay, sure, great. I think it's scalable. I don't know if it would be scalable in the exact form. Definitely the target is the Health Homes Initiative under Medi-Cal. You can kind of envision other kind of policy initiatives that might focus on complex populations. Some focus on perhaps homeless populations with serious mental illness or other versions. I think kind of the commonalities that would be apparent is kind of the collaborative team-based care, the multidisciplinary team-based care that really looks at the needs of the patients and tries to address those needs, as well as the buy-in from multiple providers to kind of work on a complex situation kind of collaboratively. So I think kind of what each community might decide to work on could vary based on kind of what the political interest was and the focus of the specific population, but I think kind of the methods as far as the approach is definitely scalable.
So I think because we don't have a national health system, using HMOs to integrate care is not going away. It's becoming more common. and especially with the Omnibus Budget Act, now permanently certified integrated special needs plans. I think this is definitely becoming a trend that's going to increase rather than decrease in the U.S. And I think what we've learned in our evaluation of California trying to do this on such a large scale, a lot that we can contribute to other states is what we've learned about the implementation and the transition and the notification of beneficiaries and how, passive enrollment and those sorts of things. So, certainly it's applicable to this trend that's increasing rather than decreasing.
I do think our efforts are scalable. I think San Diego was in a unique position because we are a little bit geographically isolated, and we could take advantage of that to make our efforts amenable to everybody. But San Diego is also like the 5th most populous county in the country. So it's not a small place to start. I do think that the data sharing is essential, and so building a statewide data repository, actually somewhat similar to the maternal and child mortality, would be necessary, and giving that transparent and real-time feedback would be an essential piece, but I do think that that would be something that could be achieved.
So the results in California have gotten a lot of national attention with the central role of a state perinatal quality collaborative that combines the Department of Health, professional groups, hospital associations, health plans, and community groups, and that now is being replicated in other states. The first 5 states out the door were Florida and Illinois, Oklahoma and Maryland, and North Carolina, and they all have some promising results. There are now 30 states in line to do this, and yesterday with the in Congress, there's, at least in the joint HHS conference committee report, there's new money for these programs. Assuming that it gets signed, we hope to be able to spread this to all states.
Great. Okay, please join me in thanking our opening presenters. While they're being photographed, we're going to take a brief break. Not too long, get some refreshments. We'll be right back with our next panel on market. Okay, our next segment is on markets and regulation. We have a number of papers that look at a variety of angles of the healthcare market here in California. And our papers are going to be presented by Glenn Melnick, Blue Cross of California Chair in Healthcare Finance at the USC Price School of Public Policy. And Glenn is also a resident consultant here at RAND. Lauren Baker, health economist and professor of health research and policy at Stanford University, chair of the Department of Health Research and Policy at the Stanford University School of Medicine. Richard Scheffler is distinguished professor emeritus of health economics and public policy at the School of Public Health and the Goldman School of Public Policy at UC Berkeley. Katrina Connolly, senior consultant at Blue Sky Consulting Group, which is a public policy and economics consulting firm, and Jaime King, associate dean and faculty director of the UCSF-UC Hastings Consortium on Science, Law, and Health Policy, also the co-founder and co-director of the master's program there in health policy and law. So I will turn it over first to Glenn.
Here I am. Yeah. Thank you, Alan. Yeah. The all-important clicker. Get the glasses out. Good morning, everyone. I'd like to add my welcome to all of you here at RAND today. I'll be presenting on behalf of my colleagues who actually both started here as PhD students. Obviously, they didn't study meteorology or weather since Katya is in Boston and Jack is in Chicago. But I'm pleased to present on their behalf. Let's see, here we go. Okay, in 1982, California passed legislation which turned out to be groundbreaking in terms of introducing a managed care price competition approach. Research showed, both in Health Affairs and elsewhere, that this model was working. More recent data tell a different story, however, as prices have started to go up in California for some time. In our paper, we argue that two sets of factors contribute to these rising healthcare prices, and that policymakers need to take action to restore competitive conditions to the market. Let's see. In this slide, we present data on hospital price per day over time using data from the state of California. If you look at the left-hand side of the graph covering the 1990s, price competition was still working. Price per day was actually going down. Prices were actually declining. Then, beginning in around 2000 and thereafter, this trend reversed. Prices started going up and accelerated. So by the time we reached 2016, prices have grown by 361%, and the CPI only 65%. So what happened that would cause this change in trend? We argue there's two sets of factors. First, in response to the managed care backlash, California adopted these prudent layperson standards to ensure access to emergency care. And secondly, previously freestanding hospitals joined multi-hospital systems, and some of those systems started to contract on an all-or-none basis. Prudent layperson rules included two important components. One, they instructed health plans to tell their members, go to the closest ER, even if it's not in the network. And two, you have to pay, even if it's not in the network. This ensured immediate access to emergency care services, but also inadvertently gave a monopoly to hospitals for emergencies that happened in their local market. This slide shows trend data in hospital ED utilization. As you might expect, it started to increase. On the left-hand side, you can see ED visits per 1,000 were declining, and then after 1999 started to increase and have continued to increase. On the right-hand side, you can see admissions through the ED also increased over time. So now, well over half of all inpatient admissions come through the hospital ED. These are two important trends. The outpatient ED visits increased, and the inpatient ED admissions increased. As a result, EDs now play a much more important role in overall hospital pricing. This slide shows trend data on hospital charges per day compared to the amounts collected by hospitals for commercial patients over time. On the left-hand side, you can see in 1995, even back then, charges were above the average payment rate from health plans, about $1,700. Beginning in 1999, charges surged. And now we've reached a level of almost $20,000 per day, and the differential between those two is now $12,000. Keep in mind that under the prudent layperson standard, hospitals have to pay for out-of-network emergencies. Hospitals typically will start with a bill that says our bill charges are the price. Legislation and rules came through to determine what's called reasonable value. It's vaguely defined, and oftentimes hospitals demand and collect close to 100% of their bill charges. This gave them tremendous leverage in negotiating contracts. Sign a contract with us at a higher price for your in-network, or we're going to leave and we're going to bill you this much higher price for the emergency patients that we're going to get anyway. The other important factor that emerged is hospital systems. More hospitals joined, and some hospital systems started to negotiate as a block. You need to take all our hospitals or you get none of them. All right? For the systems that were able to do this, that gave them also tremendous leverage to demand that all of their hospitals be in the network, and they could get higher prices than they would otherwise. The next slide shows the trends in prices in the two largest hospitals systems in California. That's the red line, compared to prices for all other hospitals in California. That's the blue line. Price here is price per admission. It's adjusted for case mix, cost of labor using Medicare wage index, and outpatient volume. And you can see on the left-hand side, in 1995, around then, prices were the same between these two groups. Again, beginning around 2000, when it's reported that these two systems started to negotiate on an all or none basis, their prices started to rise faster, and now there's a substantial differential between the two groups, over close to $7,000 and more than 25% higher for hospitals in those two systems. Okay, let's see. Almost 2/3 of all California hospitals are now in systems. We argue in this paper that hospital consolidation is a major factor driving increased prices in California. Professor Scheffler will talk later about vertical integration and its impact on prices as well. Overall, we conclude that these two sets of factors have eroded the competitive structure of the market and the competitive dynamic needed for the California model to work and get us to a point where prices were controlled. To help us make this point more memorable, we borrow and adapt the title of one of the most memorable health affairs papers, and to honor and remember our most beloved health economist, Uwe Reinhardt. I'm sure those of you who are a fan of health affairs will remember this paper title, and only Professor Reinhardt could get away with using the word stupid in a title, and it becoming one of the most popular. Our point here is this. Under the competitive model, we need robust competition, and we need to have policymakers and others work to restore it. Where will those changes come from? They'll come from three different sources. Policymakers need to deal with the fact that hospitals have this pricing monopoly over ER services and limit the prices they can charge for those kinds of emergencies. Legislators need to think about how they're going to do that. We also need antitrust regulators to change the way they look at healthcare markets and hospital markets, broaden their view to take into account that multi-hospital systems, even if they're not in the same geographic area, can combine and consolidate to raise market power and raise prices. The big concern as a health economist is, will these changes come quickly enough to slow the momentum that we see towards a more centralized government-run system? Thank you very much.
Good morning. It is terrific to be here. Thanks to the folks at Health Affairs and everybody who put this on. I'm going to talk about a couple brief remarks about this paper I worked on with Alan Enthoven, my colleague at Stanford. And we kind of took this as a chance to reflect on managed competition, of course, a model that Alan put together, colleagues many years ago. And I will tell you, he still has plenty to say. Alan is 88. And you don't just edit this paper and send him some comments and figure that he's too busy skiing to pay attention to them. That part didn't work. So he has plenty to say. And I'm sure it would add lots to what well, maybe there's a 5-minute limit, so he wouldn't add lots, but he would try if he were here. So the basic idea of managed competition, of course, is to energize changes in the healthcare system by creating conditions in the insurance market that prompt better delivery of high-value care, keep prices under control, and things like that. So Alan had a number of principles, and others that he worked with had principles that would try to do that. And consumers should be able to purchase insurance plans from a competitive structure with multiple choices. They should have to pay the incremental amount that they would face if they bought a more complicated plan or more expensive plan. And there should be other components of assistance in making informed choices, information available, and things like that. So we wanted to reflect on how that's gone in California. There's actually lots to reflect on. If we count them up ourselves, there are 4 or 5 million people in California in something like a managed competition framework. That would be something like the Covered California folks, the CalPERS folks, the FEHBP folks. Stanford's got a little version of it down my way, the University of California, some private exchanges and things like that. So those all vary to some extent in their specifics, but they all have something to do with the principles of managed competition. So 4.5, maybe 4 or 5 million people, something like that, is a lot to talk about. And there are some successes in there. Covered California, of course, has done some nice things with the market, and if you talk to other folks at some of these other organizations that I talk to, they'll tell you nice things about their managed competition model as well. But at the same time, 10, 15% of the California population something, but certainly hasn't revolutionized and taken over the state. There continue to be challenges in California, like a lot of places, with healthcare costs and value. And so what has managed competition done? What has it not done? We make some observations and talk about a few different issues, and I'll be very brief, maybe pick out a couple of them. I will skip over the first one that I guess we almost take for granted in the paper, but that is it's managed competition, and it involves a certain amount of competition. And you just heard about challenges to that and worries about that, and you will hear more about that, I think, from others on this panel maybe later in the day. And so you should just take that for what it is. We're talking about a competitive model, and the idea is how to make that work well. And if we don't have competition enough in our provider markets, or we don't have competition enough in our insurance markets, some of these ideas really just won't be able to do what we hope that they would do. And so that's an important underlying component of all of this. But I think we talked a lot about two other things that I'll highlight. One of them is incentives. So as originally conceptualized, managed competition involves a set of choices for consumers that are integrated organizations where the insurance operation is integrated with the healthcare provision operation. And there are distinct, non-overlapping provider networks so that you really create a set of choices for people to look at and try to think about the opportunities that they have for buying different products at different prices and different qualities. It's pretty clear that this isn't what has characterized the California market over time. We have Kaiser Permanente, and that's one version of this. But the examples of managed competition in California that exist do not always use or do not otherwise use that sort of model very often. And so you get an interesting set of questions. One of the things that integrated model does is it makes it very easy to align the incentives of healthcare providers with plans and ultimately with their consumers. Providing lots of unnecessarily expensive care is easily disincentivized in those kinds of structures, much more so than in some of the arm's length contracting, and especially with fee-for-service that we often see right now. And so I think you get an interesting question about whether some of the opportunity in managed competition would be better realized if we were able to create better incentives and better organizations. And so we were interested to discuss that. Interested to observe to some extent the market moving in those directions. Vivity in Southern California, Canopy up in, for those of you following all the little innovations in the marketplace, up in the northern part of California. Sutter is trying to offer an HMO, all of these different things and others going on where you do see some moves toward integration of incentives between plans and providers, all of them in different ways to different extents, offering what should be interesting experiments in terms of how we can create incentive alignment. So it was one of the areas that I think we would suggest is important to watch. Getting those incentives right would help a lot, would really make it possible for competition to have the strongest effects that it might be able to have in the marketplace. Second one, just really briefly, is a set of observations about scale and context, and I'll just make one observation. I think at one point some folks thought that the best way to do this would be to create a model in which employers would start to shift into managed competition frameworks, and that a good way to do that would be through private exchanges and other organizations where you could offer a managed competition-like set of choices to a wide variety of Californians. And the experience is that hasn't happened maybe the way that everybody hoped it would. Certainly not to the scale or in the way that people hoped it would. And it raises some interesting questions about whether, if you're going to do a competitive model with a managed competition kind of framework, whether you need scale like Covered California or like CalPERS to make it work. And if you're going to do that, how do you deal with all the employers out there who are maybe a little reluctant to shift their employees into a new model, or maybe not interested in changing their current frameworks? And so we also make a few observations about that. It might take changes to the employer model. It might take changes to the tax incentives to make employers more interested in using these broader frameworks where you can create a better set of competitive incentives in the market to make something work. So we talk about other things too, adding information, the importance of choice by consumers and things like that. But maybe that's enough for my 5 to 7 minutes and enough to get us started. Thanks.
Gesundheit. God bless you. Well, I do think that California will lead the way. It's the first state to allow a right turn on red. It will be the first state to, I think, have universal coverage and move left with this new administration. So I'm hopeful. It's a state with a big budget surplus, and there's money around, rattling around in this healthcare system in California. We just have to figure out a way of putting it all together and using it wisely. So my co-author, Dan Arnold, is here. Raise your hand, Dan. And Chris Whaley is also a co-author, actually works at RAND, but is unable to be here today. These guys take all the credit. They did all the heavy lifting in this paper. And of course, I take all the credit standing in front of you, but I'm grateful, grateful to them. My work was funded by the California Healthcare Foundation and the Commonwealth Fund in New York. I'm going to be, of course, talking about California, but let me assure you that what I say about California is nationwide. How do I know that? Because I'm working on it nationwide, and this presentation is simply what's going on in California. I'm going to be talking about something that I think Peter Long hopefully would agree, which is a mega trend in our healthcare system. And probably, for me, the most fundamental change I've seen in the organization, financing, and delivery of healthcare in the United States, and that is hospitals buying physician practices, what we call the small vertical, under the radar vertical, not the mega vertical of CVS and Aetna. And my paper will be talking about that. And what's interesting about the paper is, of course, we have both horizontal consolidation that people are well aware of, this new vertical, which has been like a hurricane, quite frankly. You'll see it in some of the data. And the combination of putting the two together, what that actually does for prices and premiums. In a particular market, we're going to look at the ACA. So that's pretty much what I want to talk to you about. And I did take seriously the instructions of 4 slides. So hopefully, this is number 1. So in order to get away with stuff in health affairs, they limit the number of charts you can use. I'm sure you're all aware of that. Many people in this room are authors. And so on this axis here on the right-hand side is this famous Herfindahl index that everybody uses to measure market concentration. It varies from 1 to 10,000. The important number for public policy is the guideline number up at the Federal Trade Commission or Department of Justice is in fact 2,500. So they would say that any market that has a Herfindahl over 25, there is prima facie, almost per se case that the market is concentrated and it will lead to higher prices. So what you can see in California is well known, as Glenn talked about it and Lauren alluded to it. The market is heavily concentrated, and what you can see on the hospital side, it's flat, but basically we're over 7,000. Now this is for 40 of the 58 counties. I should say I did that because these are more homogeneous. So if you looked at counties like LA or some of the bigger counties, obviously with more population, the numbers are slightly lower, but they're still amazingly high. And if I could throw up 3 more slides, I would show you that, but they're all in the paper, in the appendix of the paper. You'll be able to take a look at that, because we've done that for every county in California. The other thing to tell you, counties are convenient for research, but they're not what the Federal Trade Commission or the Attorney General's office uses when they're looking at markets. There are other ways of defining geographic markets. I could give you a lecture or 2 on that, but I won't bother you. But counties are good for research purposes. We have data and the trends make sense, but these geographic markets are often very case specific. in a particular area, and it has to do with transportation, contracting, patients' ability to drive in and out, all sorts of stuff like that. So what you also see is the insurer concentration, HHI, is 3,000, relatively flat. And then the primary care has gone up a little bit over 2,000. And then you see the specialist HHI, which is over 5,000. So in California, we have a heavily concentrated market for specialists. Some are amazingly concentrated, like orthopedics and others, and you can see the price spikes in those. Now, moving to the other axis, you see there, that's the percent of the physicians whose practices are owned by hospitals. And so that is the new mega trend. So you see the specialists starting more or less at 20%. By the end of the period, we're up to 55%. And so this is a short time period of 6 years. That's the mega trend, that red line. And then the blue line, dotted line, shows the same thing for primary care physicians. We have this specialty by specialty, but this is a summary. This is the mega trend because patients, consumers, the world out there does not know when they see a doctor who the doctor works for. The doctor works now for the hospital and a healthcare system, and that financial arrangement and those incentives are totally different than when the patient's used to going in and seeing the doctor. This is a fundamental change. So this is a megatrend. As I pointed out at the very beginning, you see the same thing all over the country. California is in the middle of this trend nationwide. It's not an outlier. Just a minute on this. So, of course, California is a big state. So what we did was to do what we called in the paper hotspot analysis. This is to kind of get the attention of the Attorney General to this issue. So here the hotspot puts vertical and horizontal concentration together just by scoring them 1, 2, 6. And so the scoring is in the footnote. I don't have time to go through that. You can look at it in the paper. But if you're a 6, which is the, I guess, red, you're high on all of those. You're high on vertical integration for primary care, for specialists, and you're high on all the horizontals. So you can see we have enormous variation in the state, and a lot of it, not surprisingly, the red and orange is in the north. This is consistent with a previous paper we put out at the Petra Center, which shows on average that prices are 30% higher in Northern California than Southern California. And it has to do a lot with this map and this concentration. So one small simulation in the paper, and what makes the paper, I think, a unique contribution, because there are other people who have written things on this. Our data is more up to date, more recent than the trends, but this shows the impact of the combination of vertical and horizontal concentration. So on the horizontal is the HHI of a hospital, going from 3,500 to 7,000. And then the red line and the blue line are this measure of consolidation, or the vertical part. That is hospital systems buying physician practices. So what you see is the 1-2 hit. As the concentration ratio goes up, by the way, the dependent variable you can see is ACA premiums. You can see when you put a heavy concentration together at a hospital and the vertical integration, you see the spike going up in the premiums. So this is 2 simulations. I won't go through how we did it, but it's in the paper. One simulates 35%, the other is 55%. And so the difference there is about 11 or 12% in premiums at the end of the year. So this is an enormous impact. So it's the combination of this vertical and horizontal. The horizontal is pretty much done. The vertical is the issue. So I just got the yank from that. So the summary of the key findings you can find in the paper. And thank you very much for your attention.
Hello, my name is Katrina Connolly, and I'm here to present our paper on medical loss ratios. I'd like to acknowledge my co-author, Lynn Finocchio, who couldn't be here today. I'd also like to thank the California Dental Association for funding the data analysis piece. The decisions about the data analysis, the conclusions, and policy recommendations belong to myself and my co-author. So medical loss ratios are a financial measure that can be used as a spending minimum on health services. Basically, if you pay $10 in premium and your plan spends $8 of those dollars on services and $2 on administrative costs, the plan's MLR is 80%. The Affordable Care Act requires health plan to meet an MLR threshold to ensure that consumers receive value for the premiums that they pay. Passing this requirement involved a lot of deliberation and consideration and a long process undertaken by the National Association of Insurance Commissioners, the NAIC. The ACA did not set a minimum MLR for dental insurance, but California law in 2014 required plans to submit MLRs for all of their dental products. So this data set provides a great opportunity to take a first systematic look at a large state with a heterogeneous dental market. We decided to compare these data against 3 MLRs. One, that MLR is set by the ACA, but that applies to health insurance companies, and there are a few differences between the dental market and health insurance. For one, dental products tend to have lower premiums than health insurance, which I'll come back to that later. There tend to be lower claim volumes and stricter utilization. We also compared it against a threshold that was proposed in California legislation. The legislation was passed in 2018, SB 1008, but the threshold was not included in the final bill that passed. That threshold was 75% for large group markets and 70% for small group and individual. We also compared it against a lower threshold that was in the NAIC guidelines used for the ACA, but it was not particular to dental. Again, there's no dental agreed upon minimum for dental, but this was 60%, and we selected that because it shared a feature with the dental plans of optimal renewability. So we did some simple descriptive statistics just to get a sense of the lay of the land. We found a huge range of MLRs from 4% to 126% with a standard deviation of 21%. The mean was 61%, but when weighted by covered lives, that was 76%, which indicates there are a lot of products with lower MLRs, but most insured individuals in California are covered by products with higher MLRs. We also found that dental PPOs tend to have higher MLRs than HMOs, as well as large group markets have higher MLRs than products in the small group and individual. Very few products reached the ACA threshold, 9%. 29% of products reached those proposed in the California legislation, and 57% reached the thresholds proposed by the NAIC, 60%. So though few products reached the ACA threshold, most Californians were served by products that met the other 2 thresholds. 80% of Californians were served by products that met the NAIC threshold, the 60% threshold, and 67% of Californians were in products that met the Californian threshold. So clearly product size and type matter. Generally, the more lives insured by a product, the higher the MLR. This suggests that plans are able to derive economies of scale from larger enrollments and thereby offer greater value to consumers. But while this suggests that size matters in achieving higher MLRs, there were still some products that had enrollments less than 5,000 who achieved MLRs above 80%. So it's possible to provide value for consumers at a smaller scale. It's important to note that millions of Californians were served by products that did not meet these thresholds, which suggests that consumers in these products may not be receiving sufficient value for their premiums as indicated by this consumer protection tool. The policy implications include that clearly dental products with large enrollments can achieve minimum MLRs, but there are other products that have a tough time doing so. So we recommend in our paper that a legislatively mandated MLR could ensure better value for dental products. The question is how to set an appropriate threshold for the dental market. We consider that the challenges that MLRs, that the dental market has when approaching developing this threshold include that dental products vary widely in terms of the classes of benefits that are offered, compared to the health insurance market is much more standardized because the ACA requires the 10 essential health benefits. Also, dental insurance products, as I mentioned before, tend to have lower premiums, which means that administrative cost tends to be a higher share of the premium. And dental products also have higher cost sharing requirements for higher classes of benefits. So the more expensive and involved the procedure is, the more the patient is paying out of pocket, which is very different from most health insurance plans, which can make it more challenging to anticipate the amount of benefits that members will actually use when setting the rates. As for what could be done, how legislators might approach developing MLR thresholds to continue enabling a wide array of choices of products on the market. Legislators could consider a differentiated set of MLRs. So, for example, having varying MLRs depending on the size of the enrollment, or having clusters of benefit classes. And plans could also legislators could also develop MLR corridors linked to average monthly enrollment, or consider a phased implementation of a few years. As for consequences, rebates are often used. They're used for the ACA, for the health plans. That can incentivize plans to find efficiencies in administrative costs or lower profits, but it can also result in plans responding by raising premiums or leaving the market. So instead, states could require dental plans to file corrective action plans to specify how they will meet the threshold in a required time period, and/or states could allow plans to justify higher MLRs. So we recommend that the NAIC could really contribute here by studying this issue in the same way that they studied health insurance and develop MLRs according to features particular to the dental market, such as benefit classes and cost sharing requirements. Thank you.
Hi, I'm Jaime King, and I'm so honored to be here on behalf of my co-authors, Catherine Goodixson, who's here, can you stand up and wave, Timothy Brown, and Chris Whaley, who I think is maybe the only author to be on 2 papers on one panel this morning. So congratulations, Chris. And I'm going to discuss our paper, California's Drug Transparency Law, Navigating the Boundaries of State Authority on Drug Pricing. So 2018 was a really big year for the state regulation of pharmaceutical drugs. 44 states introduced and 29 states passed legislation designed to increase the accessibility and affordability of prescription drugs. In state houses around the country, legislatures sought to increase price transparency, require manufacturers to report their prices and how they calculate them, to prevent price gouging and regulate pharmacy benefit managers and allow drug importation from Canada. And fulfilling its role as an innovator state, California has once again led the way towards price transparency and reporting, with Vermont, Oregon, Maine, and Connecticut to follow in 2018. In October 2017, Governor Jerry Brown signed Senate Bill 17, a bill that seeks to improve drug price transparency and enhance price negotiations by requiring specific disclosures from certain health plans and pharmaceutical manufacturers. So key features of SB 17 are that all plans that register with the Department of Managed Healthcare or the California Department of Insurance must disclose the 25 most costly drugs, the 25 most prescribed drugs, the 25 drugs with the greatest increase in annual spending. And in addition, large plans must designate the proportion of premiums and premium increases due to pharmaceutical drugs. In addition, pharmaceutical manufacturers must provide registered purchasers with 60 days notice of an increase that's more than 16% in the wholesale acquisition cost, or the WAC, which is the manufacturer's list price, but not including rebates or other discounts. Now, this increase is measured cumulatively over the current year and then the prior 2 calendar years. So it can be almost up to 3 years with that increase of 16%. Now, for drugs with triggering increases, manufacturers must provide the Office of Statewide Planning and Development, or OSHPD, with quarterly reports that provide information on sales, the patent timeline, the prior WAC, and the financial and non-financial factors used in the decision to increase the price. Now, manufacturers must provide OSHPD within 3 days of the release of any new drug that has a wholesale acquisition cost above the threshold level for specialty drugs under Medicare Part D, which is about $670 a month. In addition, manufacturers must provide OSHPD with information on those new drugs, their usage, factors they use to determine the WAC, and marketing materials within 30 days of releasing that drug. And so SB 17 also limits these disclosures to information that was in the public domain. And it did this very carefully. It did it to avoid running afoul of trade secret protections, as Nevada's SB 539 did. And that brings me to one of the most interesting features of SB 17, the way that it attempts to maneuver through the shifting landscape of state regulation of pharmaceutical drug pricing. So states attempting to increase pharmaceutical price transparency and regulate escalating prices must be prepared to navigate some fairly tricky waters with a lot of perils ahead, and I'll discuss 3 of them. So first and foremost, any state taking on the pharmaceutical drug pricing should expect a vigorous challenge from the industry, right? They appear to be guarding this territory quite vehemently and are clearly trying to establish favorable precedents about their ability to dictate prices and to keep them secret. And California appeared very poised and ready to take on this challenge when it passed SB 17. Legislators drafted the law to avoid being preempted by the Employee Retirement Income and Security Act, or ERISA, by only having SB 17 apply to plans that were regulated by DMHC and CDI. The agencies don't regulate in this manner self-insured employer plans, which are so frequently trigger ERISA preemption. And as I alluded to earlier, it sought to avoid claims that the law violated trade secrets protections by only requiring information that was either already in the public domain or would be aggregated when it was disclosed. So they weren't going to violate any, share any information. Second, state and federal laws implicated by pharmaceutical pricing legislation are highly complex, and the state's ability to intervene in these areas are not clearly defined, making drafting a law in this space somewhat educated guesswork. So despite the best efforts of California legislatures, Pharmaceutical Research and Manufacturers of America, or PhRMA, challenged SB 17 for violating 3 constitutional provisions: the Dormant Commerce Clause, the 14th Amendment, Due Process Clause, and the First Amendment. Of these, the Dormant Commerce Clause is the most relevant, has the most outside relevance, so I'll say a little bit more about that. And as you may know, Maryland's anti-price gouging law for generics got hung up and thrown out on the foundation of the Dormant Commerce Clause. So the Dormant Commerce Clause is a judicial interpretation of the Commerce Clause. It's not part of the Constitution, but it's a judicial interpretation of it that holds that states cannot unduly burden interstate commerce. A state can't say what happens in commerce that occurs outside of its state, right? Okay, so over time, Dormant Commerce Clause jurisprudence has evolved in ways that have made it a little bit of a moving target, especially right now. So in the case of SB 17, pharma claims that SB 17's 60-day notification requirement violates the Dormant Commerce Clause by preventing manufacturers from raising their price in all 50 states until California, and they're like, look at California, they think they deserve 60 days notice, right? Until California's had 60 days notice. Now, pharma's complaint was recently dismissed by the district court in the Eastern District of California for lack of standing. And what that means is that it doesn't mean that the case was thrown out or that the Dormant Commerce Challenge doesn't stand. What it means is that pharma didn't establish that any of its members had been harmed or were in imminent danger of being harmed by the law. But they have 30 days to do that, and I suspect that they have more than enough evidence to suggest that, and the judge sort of alluded to that in the opinion. So it's really important to recognize that the Dormant Commerce Clause issue in this case has not been settled. This brings me to the third and final challenge that I'll raise, is that crafting a law that will successfully avoid federal preemption and survive these withering legal attacks also risks that the state ends up passing a law with little substance and teeth, right? What you have to do to get through all of this makes it a challenge. And so these perils make it especially daunting for states to pass an innovative law that would actually make significant progress in increasing drug price transparency and affordability. Now, within this treacherous environment, SB 17 probably made about as many strides as it reasonably could. It navigated the foreseen challenges of ERISA and trade secrets protections. It sought to clarify the current boundaries of the Dormant Commerce Clause, and it improves reporting and transparency of pharmaceutical utilization and spending within its state. And so where do we go from here? States with the resources and the means to do so should keep passing legislation designed to test the boundaries of state-based pharmaceutical price controls. They should also encourage the federal government to amend ERISA in ways that allows states to govern all health plans and pricing in different ways. ERISA is currently crushing us on health reform right now. And thirdly, they should strengthen existing transparency efforts with consumer-focused initiatives like reference pricing and right to shop initiatives, and provide other stakeholders with pricing information to help them make better treatment and payment decisions. Okay, thank you so much.
Panelists can come up for.
It's quite a step.
So we ran a little long, so I'm going to see if there are questions in the audience before I turn to mine, because there's some really interesting papers here. I'm happy to lead off in the questions, but I don't want to short you of your time. You guys are way too shy. You need to come to Washington. You're going to right here. If you could wait for the microphone and identify yourself.
Hi, thanks for the talks. They're really interesting. My name is Daniel Cruz. I work for Axion Health Partners, and my question is specifically for the hospital research that you guys did. There seems to be two kind of approaches to controlling cost. One is the integrated care delivery system, where it's more about disease management, care management for the population. And the second level seems to be the role that competition plays on decreasing costs, where perhaps different prices from hospitals compete to lower the price amongst health plans that will reimburse them. Do you see these two ways of controlling cost as compatible with each other, or are they ultimately competing against each other, that more integrated care is going to lead to less competition, or if you do more competition, it's going to lead to less integrated care?
You go first. All right. Well, I think this is absolutely one of the questions that we have to confront, right? There are great observations of integrated systems that do a nice job of providing care and that show you that integration is an important part of getting us to where we want to go. And we also see lots of evidence that consolidation in the form of creating integrated systems has led to increase prices in a lot of cases. So how do you put that together and navigate that is, of course, the key policy question. I think there are a number of things we could talk about, and folks here may want to talk about them. You don't always have to be financially integrated in order to be clinically integrated and achieve some of the benefits of care improvement that you could get. There's an interesting set of questions around the scale. You may not have to be really huge and dominate your market in order to create some of the clinical benefits that could come from integration. And so trying to figure out what that sweet spot is, how we get the integration we like without the consolidation and the market concentration we don't, is really the key. And it seems to me that in some of these directions, trying to get the right kind of integration, trying to figure out how we get large enough scale but not too large scale is a regulatory, maybe a legislative, maybe another market kind of question.
I'll take a brief shot at that. First saying, for a change, I agree with another health economist.
Yeah, good.
I think the evidence on the impact of this consolidation on prices and premiums now is convincing. There's a huge number of studies that show that. I don't think the evidence yet on the improvement of quality of care and integration and better health outcomes is convincing. So my challenge is, if the other side thinks that care integration is improving quality, they need to make their case. Now, having said that, that's the challenge. Now, in the integrated delivery systems and the competition, this is a challenge. I think we need to think about how to make these large integrated systems compete with each other. And as Laurence suggested, they don't have to be bought. There are other ways of having both clinical and financial integration by contracts. The big issue, this is my last thing from the antitrust perspective, has to do with foreclosure. When they integrate and buy these physician practices, in my case, they basically keep competitors out of the market. And that is the antitrust issue. So we do have law enforcement that can deal with that as soon as they wake up now, and I think they are, and see what's going on.
I agree with, I don't know if this is working or not. I'll try yours. Yeah. Thank you, Professor. I agree. I'm not optimistic that the ACO movement will produce much savings because it will end up consolidating markets more. And even if you have better coordinated care, better managed care, better quality, better outcomes that reduce the amount of care used, I'm afraid the prices will just be increased to offset the lost volume. Between 1995 and 2016, hospital volume dropped for commercial patients 20% in California. So demand has actually been going down, but still spending has gone up tremendously. So it's really pretty much all about the prices. And the question, so I'm not optimistic that the ACO model will deal with that.
Edie here.
Could you talk about the potential of regulating prices according to costs and also regulating the managed care entities so that they're competing against each other on actual health outcomes, such as what you saw in the article about reducing heart attacks? So they're competing on the hard outcomes and regulating the industry according to transparent quality metrics.
Good.
You want me to take?
Yeah.
So I think it's an interesting idea. I think it's something that would be really fantastic to like think about how we would implement it. I do think that you have to then have the regulatory authority to be able to control prices in that way. And I think that from a state to try and do that, you have to figure out which mechanism is the right way to do that. Are you going to try and regulate premiums that are going to the insurance companies, or are you going to try and regulate the providers and determine payment from them specifically? And then because you're getting into two different types of regulatory entities, that gets really tricky. If you try to regulate the insurance plans and their premiums through that way, you run into ERISA problems. if you try and regulate self-insured plans, and if you try and regulate at the level of payment to the providers, then you're cutting the insurance companies out, presumably, in this model. And I think it's an interesting place to start, but you're going to run up to some challenges on that.
I would just add that it's, I agree, and it's really hard to do cost regulation in an industry that doesn't know what its costs are all the time. So I think one of the challenges in this approach is just figuring out how we would go about tracking that and putting together a system. And it's probably one of the real situations where the devil's going to be in the details. Could you do it, and could you figure it out, and would it be appropriately reflective of the high-quality organizations and things like that?
Just to add 2 cents to that, they know what their costs are, but they're different numbers for different people. So it's in the eyes of the beholder of how they report their costs. I'm not a big fan of price regulation. I think it's basically, I understand Medicare does that, and it has a role in doing that, but I think to have a market operate correctly or do anything to be competitive, I think regulating prices is not something that I would support. I think it's been a failure wherever it's been tried in the United States in healthcare, and even in Maryland it's been a failure. Maryland works because it gets a huge federal subsidy to make their system operate. So it's basically been tried in various places, and I don't suspect it's going to work very well in California, though there are people who are frustrated about the prices, but I think we are still thinking about using a market in California, and I think regulating prices for the top, even if they knew how to do it, and I don't think they do, would not be a good idea.
I just saw this week there's a ballot initiative in Palo Alto, which is to regulate prices at 115% of costs, and that's on the ballot in November. So if that passes, we may see a live experiment here in California.
Hi, good morning. Tom Prislak, Cedars-Sinai. Just an observation and then a question for Glenn. The observation, just to say that I've heard a remarkable number of assumptions and preconceived notions expressed this morning, and being someone who's been associated with health affairs for the better part of 30 plus years, I would encourage, in the spirit of health affairs, organizing discussions that provide for competing views and the use of information to develop points of view on both sides of what is, I think, one of the most important domestic issue facing the country. Back to the purpose of the Q&A as I understood it. Glenn, a question for you. What is it in your data that gives you reason to believe that the trend in charges that you described is specifically related to the provision, that the law that was passed to assure reasonable access to emergency departments? And related to that, I think you're aware there was a law passed several years ago now, including during your study period, that places limits, actually, on what hospitals can be paid when they're out of network, and not the blank check that your article suggests. Thank you.
Sure, thanks. So I think there are a number of factors that influenced the surge in bill charges. I think, and so I'm interpreting the data and I'm offering hypotheses as to why. But the fact of the matter is, once those charges went up, that provided leverage for hospitals to say, this is our price, and therefore, if we go out of network, this is our price. In terms of the limitation, my sense is the way that those regulations have been implemented is it's not a hard and fast rule. And so there are a lot of instances where typically hospitals will demand 100% of bill charges. That's the starting point in my experience in the world that I see. And then there's a fight over what's reasonable value or usual and customary. Hospitals have been pretty successful in getting others to agree that close to 100% of charges is their usual and customary. The point is, it creates tremendous uncertainty to the plans, who ultimately say, we don't want to deal with this, we're just going to sign the contract and move on. Since every other plan faces this same uncertainty we're not at a competitive disadvantage. Let's just not worry about it, and we'll deal with something else. I agree with your suggestion. I'd love to sit down with other folks from the inside who look at things differently to further all of our understanding.
Yeah, and I'll just say from a health affairs perspective, when we publish an issue, it's the authors whose work has been through peer review who have the voice, and that's why they're here. I mentioned at the outset this morning, we're going to do an event in October in Sacramento, and we do other events like this that go beyond the authors, that are designed much more to have the kind of perspective, the range of perspectives. It's not that we don't want the range of perspectives in authors, but that they're really primarily presenting their work. Let's take one last back here before we switch panels.
Lily Mahawk, I'm an internist at Cedars-Sinai. I work with Tom Preslack. One of the questions that comes to my mind as I'm listening to all these presentations is, as an internist, someone delivering care and trying to create the best value for my patients, and we discuss how costs are going up and consolidation is going up, and we're trying to come up with all of these solutions like integrated delivery and population health care. Who's making the money? Where is the money going? Because I want to be able to talk to my patients and say, yeah, you know, your costs are going up. We're trying to create better care and value for you. And this is the reason we have a problem. And I feel like that's part of my reason for being here and participating in this conference, is to try to understand where is the money.
I'll take a quick shot at that. Because in healthcare, when you want to do a health policy, I've been telling my students for close to 40 years, well, everybody else says, follow the money. So it's really an excellent question. So who's making the money? Hospitals are fat. That's why they can buy all these physician practices. In Northern California, they can build new hospitals and facilities. So there's a lot of money in nonprofit hospitals. Secondly, there are most of the insurance companies, not Blue Shield, of course, are for profit. And so you can look them up on the stock exchange, and you'll find out that they have performed between 2.5 and 3 times higher than the average stock price increases in the last 10 years. So they have made huge amounts of money in the healthcare industry. And, you know, I understand that you're not out to make a lot of money, but doctors get paid pretty well, and so I think that there's some money in the healthcare system too, dealing with doctors and these large medical groups now that have morphed into big companies and corporations that have been bought up and sold in the marketplace. So I could go on, but I think I'll stop at those 3.
I would just say there's inefficiencies throughout the system in terms of markets. And so, hospitals, one of the things that drives hospital prices is their costs. And their costs go up every year. If you look at their major costs, 50 to 60% is salaries and wages. All right, and it turns out a lot of the inputs are professionals whose entry into the field is controlled by the profession. So we have limited supply. If you look at doctors, you look at dentists, all of our professionals in the healthcare system, supply is quite limited. And many of the professions are very effective at controlling entry, which keeps their prices of their members high. And so one of the big inputs is expensive.
It sounds like with MLRs of 4%, there may be a little money in dental.
Shout out to dental.
I want to own that plan. Okay. I think it's fair to say this is a complex topic. It requires more conversation, but it also requires some really exceptional empirical work, and that's what we're privileged to present today. So please join me in thanking our authors. Okay, we're going to get, I think we have a picture coming, but we don't have a break. We'd like to really keep moving so that we have time to get through the material. I'm going to ask my next group of authors to come forward. If you need to slip out, do so quickly and come back in. I'll just move with the introductions for those presenting on various dimensions of access to services. Ulrike Muench, Assistant Professor at the UCSF School of Nursing and faculty at the Philip Lee Institute for Health Policy Studies. Dawnté R, Senior Statistician at the UCSF Family Pact Monitoring and Evaluation, Office of Family Planning, and California Department of Healthcare Services. Malia Jones, Social Epidemiologist at the University of Wisconsin-Madison's Applied Population Laboratory. Emily Arnold, Associate Professor of Medicine in the Center for AIDS Prevention Studies at UC San Francisco. Arturo Bustamante, Associate Professor in the Department of Health Policy and Management at the UCLA Fielding School of Public Health. And Ken Jacobs, Chair of the Labor Center at UC Berkeley. So I'm going to step down, turn the microphone over to our first speaker, and we'll move into the topic of access to services.
Oh, no break. Let's see. Okay, so to begin, I would like to acknowledge my co-author, who is also the lead author on this paper, Joanne Spetz. She is also at UCSF, and as you see, she has many affiliations within UCSF. So, as you know, California, just as the rest of the United States, has a primary care provider shortage. And this slide shows you the projected supply of physician's assistants, nurse practitioners, and physicians for both 2025 and 2030, and then also the forecasted demand for the same time period. And the report has a lot more detailed, or these numbers come from a report that also Joanne and co-authors published through UCSF. But they show, just as the rest of the United States, that there are many, that the variations are really by regions. And so the takeaway from this slide is that even if we were able to use all the primary care providers available to us, we would still experience a shortfall of about 5,000 primary care providers in both 2025 and 2030. So the key question that we wanted to address with our study was, to what degree are nurse practitioners concentrated in areas that have fewer physicians? And what would be the characteristics of these NPs that are associated with where they work? And this is important, of course, because our workforce strategies would need to be addressed in a certain way, depending on these regional differences. So we fielded a survey on nurse practitioners that was commissioned by the California Board of Registered Nursing. And it included nurse practitioners and certified nurse midwives, but our findings for this study was for nurse practitioners only. And the questions that included were on employment patterns, degrees to which NPs provided primary care, practice barriers they face. And we had 171 NPs that responded to the survey with a response rate of 56.5%. We also obtained some other data, the number of primary care physicians by county in 2015 of primary care physicians that worked at least 20 hours per week, and the number of newly licensed NPs by county in 2016. And we used these numbers to calculate the numbers of primary care physicians, primary care NPs, and newly licensed NPs per capita. We began by calculating and mapping the distributions of NPs and physicians by higher than average density of primary care physicians, NPs, and both using the statewide averages for a population of 1,000. 23 counties had higher than average density for both nurse practitioners and physicians, and those are the green areas on the map here. And 10 counties had higher than average density for physicians only, those you see here in red. And only three counties had higher than average density for nurse practitioners, and they are in blue. The correlation between the NPs and physician densities was 0.63, indicating that counties that had high density of primary care physicians tended to also have higher density of nurse practitioners. We also calculated the density of the new NPs that you don't see on this map here, and found that they were concentrated in the same areas as all the other NPs. So this raises concerns about whether the new nurse practitioners are going to where we are currently experiencing gaps. It's also interesting to note here that only 8 of California's 23 NP programs are located in counties with lower than average NP and PCP density. After we determined the higher than average densities, we conducted descriptive statistics for higher than and lower than average densities by demographic characteristics and employment characteristics. We also conducted 2 ordinary least squares regressions with NP and physician density as the outcomes. And we were interested then in determining what NP characteristics and other labor market characteristics were associated with working in low-density counties. Descriptive statistics showed that a larger share of underrepresented minority NPs, NPs that tended to be younger, and NPs with associate degrees as their initial nursing education were residing in low-density counties. Some other interesting findings were that more NPs located in high-density counties reported having trouble finding a job and planned to move to another state within 5 years. And in lower-density counties, a larger share reported using their skill to their full scope of practice. Our regressions confirmed our descriptive results, showing that newer grads, minority NPs, and NPs with an entry-level associate degree are more likely to work in low-density counties. What are some of the implications that we took away from our study? First, we might want to target and incentivize NPs and RNs who have come out of RN associate programs. Second, the distribution of NP education programs is quite problematic. Nearly all nursing programs in the state are located in high-density areas. We need additional distance learning opportunities, as well as NP residencies and rotational clinical programs for NPs who want to serve in underserved areas. Third, and most importantly, I'd like to mention that California is the only Western state that has NP restrictions for the way they practice. Though we didn't ask why people might want to move, other studies have found that NPs like to move and work in areas where they can practice without physician oversight. So it will be key for California to expand the scope of practice restriction for California if we want to retain our NP workforce. Thank you very much.
Thank you very much for giving me the opportunity to discuss the impact of the Affordable Care Act, or ACA, on family planning services and the provision of family planning services here in California. I'm actually no longer a senior statistician with UCSF, and this was done under my early research and consulting. And also, the clicker is gone. Totally get it. I'm nervous too. It's making its way back up here. All right. My 5 minutes haven't begun, right? Okay. Also joking. Okay. All right. So family planning produces happy and healthy families. It allows people to attain their desired number of children and to also control the spacing of their pregnancies. Family planning reduces unintended and unwanted pregnancies, as well as improves birth outcomes and saves women's lives. As the state of California pays 50% of all maternity care provided, preventing undesired pregnancies offers considerable cost savings. In fact, it has been estimated that the state sees a 7-to-1 return on its dollar investment when it invests in family planning services. In 1969, Republican President Richard Nixon launched our country's Title X family planning program, stating that it is my view that no American woman should be denied access to family planning assistance because of her economic condition. California has embraced this philosophy, and since 1996, California's Family Planning Access, Care, and Treatment Program, or Family PAC for short, has offered contraception to uninsured residents with incomes below 200% of the federal poverty guideline. Through a network of 2,200 public and private providers, Family PAC serves over 1 million men and women each year of childbearing age. Clients can walk into a clinic, enroll in the Family PAC program, get the services that they need, and often leave with the contraceptive method of their choice the same exact day. Unfortunately, not all Californians know about the Family PAC program and or make use of the services it provides. It is estimated that nearly 2 million low-income California families have unmet contraceptive needs. That's 1 in every 3 low-income California women in California. As access to contraception has been a challenge for families across the country, the ACA explicitly required that insurance plans cover all contraceptive methods without out-of-pocket costs. In January 2014, the ACA's Medi-Cal expansion increased the income cutoff to 138% of FPG and allowed individuals without dependent children to enroll. As a result, many Family PAC clients were encouraged to enroll in the family and into Medi-Cal, with a majority enrolling in the Medi-Cal Managed Care program. So to better understand the impact the ACA, particularly the 2014 Medicaid expansion, had on family planning provision, this paper looked at changes in health insurance coverage pre and post ACA, having a usual source of care, access to needed medical care or prescriptions without delay, contraceptive counseling, and prescription contraception, all among low-income women who would have been the target of the Medicaid expansion, age 18 to 44, who also would be in need of these services. We found that the ACA expansion increased coverage, meaning that the proportion of uninsured women went down as the proportion of insured women increased pre and post ACA, exactly what you would expect from the ACA. However, this was not accompanied by improvements in receipt of health care, and specifically, there was no change in receipt of needed medical care or prescriptions without delay, and there was no change in contraceptive counseling or receipt of prescription contraception from a provider pre and post ACA. Obviously, this is very disappointing. So it means that more work is needed to ensure that planning services, specifically family planning services, and the unmet needs of women are addressed. Again, we need to remember that 1 in 3 women, low-income women in California, have unmet contraceptive needs. We need to invest in contraception that is, again, improving public-funded family planning services within our state and what our state provides. We need more than just reporting on national contraceptive quality measures, and it means we need concentrated attention to expanding access and outreach to all families with unmet contraceptive needs. Our efforts also need to include training in the clinician force and our clinician workforce, and to routinely offer women access to the safest and most effective reversible contraceptive of their choice. And this is particular into intrauterine and subdermal devices. We must also carefully examine reimbursement models and the potential benefit of retaining a fee-for-service model for cost-effective preventative services such as family planning services, while moving to a managed care model for other health services. Lastly, we must do what we can to ensure that in California, every child is a wanted child, and that no California woman faces undesired risk for pregnancy. Thank you.
Good morning. My name is Malia Jones, and I'm delighted to be back at RAND today, where I started my research career 15 years ago. And at that time, I was part of putting on events like this one, so I really do appreciate and thank our hosts for all the work. I know only too well how much work it is. I'm here today to talk about our work evaluating the results of a 2014 policy change in California related to mandatory vaccines for school-aged children. And this is part of an ongoing project that I have in collaboration with my co-authors and others, Allison Buttenheim at the University of Pennsylvania, Dan Salmon at Johns Hopkins, and Saad Omer at Emory. So in California, as in all other states, vaccines are mandatory for entry to public or private schools. However, up until very recently, it was possible for parents who did not want to vaccinate their children to obtain an exemption from the mandatory vaccines for reasons that included personal or religious belief. So in our analysis here, we looked at publicly available data on 15 cohorts of kindergartners in California to assess the impact of a new California vaccine mandate policy that was implemented in the fall of 2014, known as AB 2109. AB 2109 still allowed for exemptions from mandatory vaccines, but introduced for the first time the requirement that a parent who wanted an exemption had to obtain a signature and an affidavit from a healthcare provider in order to obtain one. So it just raised the sort of opportunity cost of obtaining an exemption from vaccines. Our analysis approach here was a difference in trend analysis. So we had census data on practically all the kindergartners in California for 15 cohorts. We assessed the change in the overall exemption rates, as well as the change in the degree to which the children with vaccine exemptions are clustered within their schools and in counties. I'm going to skip over here the similar analysis that we did for another group called conditional admissions. It's an interesting and large group that's very understudied, and you can read about that in the paper. So this graph shows the prevalence of vaccine exemptions at the state level from 2001 through 2015 for public and private schools. And as you can see, prior to implementation of AB 2109, vaccine exemptions were showing a steady increase. The upward trend began earlier and was steeper in private schools as compared to public schools. And at the peak of the exemption rates in the 2013-14 school year, almost 3% of all public school students and 6% of all private school students entering kindergarten in California had some exemption on file for mandatory vaccine. In the 2014-15 school year, that was the first year after AB 2109 was implemented, vaccine exemptions began a modest decline. We used a measure we borrowed from the residential segregation literature called the Isolation Index to measure the degree to which kindergarten students with exemptions attend schools with other exempted students, so the school level clustering of exemptions. A higher isolation index indicates more clustering. And just as an example for how to interpret this thing, an isolation index of 10% indicates that a typical exempted student attends a school with a 10% exemption rate. There was strong school level clustering of exempted students throughout the study period, and it was really not affected very modestly in public schools only by the implementation of AB 2109. Throughout this period, private school students with exemptions on file attended schools where 17 to 22% on average of students also had an exemption, and exempted public school students attended a school with between 9 and 13% exemption rates. These are well below the thresholds for herd immunity commonly accepted for measles, pertussis, and other preventable childhood illnesses. And I think it's a little bit of a stretch we have to reach a little bit to figure out why I'm in the access to services session here, but I think we can think of this as children's access to herd immunity in their school environments. The map, oops, I should show you the map. The map shows the effect of AB 2109 on school level clustering by county. In most counties, the clustering did go down following AB 2109. However, really concerning, the darker colored counties show where clustering of exempted students actually increased after the implementation of AB 2109. Some of these counties just have really small populations, and we have census data. So the difference of 2 extra exempted kids can show up as a difference, right? We don't really have measures of statistical significance with census data. But we do have counties with notably large kindergarten populations and an increase in clustering after the policy change, including San Diego County, Alameda County, Fresno, Contra Costa, and San Joaquin. So our conclusions: mandatory healthcare provider counseling for parents did lead to a decline in vaccine exemptions in California, but the decline was modest. Private schools showed really very weak response to the policy change. AB 2109 had little or no effect on school-level clustering of exempted children statewide, and in some counties, including some with substantial kindergarten populations, school-level clustering increased. And the policy implications here, so these results are really not interesting at all in California because AB 2109 has since been superseded by a new law, SB 277, that eliminates all non-medical exemptions from vaccines for children. However, this trend is going on in lots of other states. Exemptions are on the rise all over the country, and many other states are grappling with how to address this problem. Some states, for political reasons, it would be very hard to consider a law like SB 277 where all non-medical exemptions were eliminated. So many states are considering laws similar to the one that we evaluated. And those states should know that this policy was really only modestly effective, and it did not address what's probably of most public health importance with respect to exemptions from vaccines, which is the school-level clustering and the within-school exposure of kids who are unvaccinated to other kids who are unvaccinated. In addition, we do need research and policy solutions that address the root causes of vaccine hesitancy and decline, and the increase in parents with strongly held beliefs about vaccines being unsafe, ineffective, or unnecessary poses a serious threat to public health. Thank you.
Good morning. The coveted pre-lunch slot here. I'd like to thank my co-authors, Shannon Fuller, Valerie Kirby, and Wayne Stewart, for working with me on this paper. They are all with me at the Center for AIDS Prevention Studies at the University of California, San Francisco. So I'm here to talk a little bit about the impact of Medicaid expansion on people living with HIV who have behavioral health needs. Where we've seen nationally, Medicaid expansion has been a real boon for populations with chronic illness. For individuals living with HIV, it was experienced with a little bit more nuance. So prior to Medicaid expansion, low-income individuals who were diagnosed with HIV were cared for in integrated, culturally tailored HIV-specific centers funded by the Ryan White Care Act. And there was a change with, however, Medicaid expansion to move approximately in California 53% of patients from these integrated care settings into Medicaid managed care. So that trend was also mirrored nationally, where we saw approximately 6% of people living with HIV move to Medicaid coverage under the Affordable Care Act. Medicaid is obviously a much more comprehensive form of healthcare insurance than what individuals were able to receive under just the Ryan White Care Act. It includes coverage for comorbidities as well as behavioral health services, particularly for people on the low to moderate spectrum of mental health needs, and those are actually enshrined in essential health benefits. As you'll see today, though, a number of individuals living with HIV continue to need coverage through the Ryan White Care Program, which provides support for comprehensive wraparound services that enable individuals to stay connected to care and on treatment. including 38% of those who are also covered by Medicaid. So with Medicaid expansion, individuals who went from a very integrated medical home, essentially, where they were receiving an array of culturally tailored services, then had to basically navigate a very complex landscape and fragmented landscape to receive care for their behavioral health needs. We sought to understand what the experiences were of people who would move from the Ryan White funded services into the Medicaid managed care plans. To accomplish that, we did key informant interviews with a total of 53 individuals, which included policymakers as well as behavioral healthcare providers and HIV specialists in 5 counties across California, including San Francisco, Alameda, Fresno, Los Angeles, and San Diego. Our interviews lasted between 60 and 90 minutes, and we transcribed and then analyzed our transcripts for themes related to accessing behavioral health care services and maintaining patients living with HIV in treatment. And here are some of our findings. Comprehensive coverage, including for behavioral health, was really a welcome development for people living with HIV. So on the whole, this was a very successful transition for individuals. However, there was a complex form of behavioral health care system that had to be navigated. And providers had some troubles actually determining where to refer their patients based on the acuity of the symptoms, which went from low to moderate, which would indicate a referral to Medi-Cal managed care network providers, or on the moderate to severe level, which would indicate a referral to the county level severe mental health care facilities. In addition to some of the complexity, there was also, once people had determined they needed to go ahead and refer individuals for specialty, there was a need for cultural competence among behavioral health care providers, particularly for populations that are disproportionately impacted by HIV, which includes sexual and ethnic minorities in California. Finally, there was a real lack of integrated care settings, which led to some patient attrition and loss to follow-up, with individual providers reporting that they had referred their patients but then had really lost them to follow-up once they were in the behavioral health care system. Ryan White wraparound services continue to be necessary to maintain engagement in care and treatment adherence. In terms of the implications of our findings, what we really are seeing is integrated care settings like patient-centered medical homes are associated with better HIV-related health outcomes, and that they have been found to be cost-effective in some settings. More robust, culturally competent, and diverse provider networks, particularly among behavioral health providers and in rural parts of the state, are really needed. Wraparound services that address housing, food security, and transportation needs, as well as childcare services for women living with HIV, really do improve HIV-related health outcomes. And finally, maintaining access to comprehensive physical and behavioral health services through Medicaid is essential for achieving viral suppression, which is a public health goal, and will help us end the HIV epidemic. I'd like to acknowledge our funding through the California HIV/AIDS Research Program. Thank you very much.
Good morning, everyone. Thank you very much for being here. I want to start thanking my co-authors and I also have a first opportunity of publishing my work. And there are 2 main motivations that help my co-authors and I begin this research. The first is that Latinos are an increasing share of the U.S. population. And in California alone, they are almost 39% of the state population. And previous research has shown that there are many differences in access to care across different racial and ethnic groups, but very few studies have observed whether these differences are actually observed as well within each of these groups. So this is among one of the first studies that actually looked at what happened with teen Latinos before and after the ACA. So with the main comparisons that we did in this study was between Mexican Latinos that are the majoritarian group. About 64% of all Latinos are of Mexican heritage. And we also tried to, that leads me to the second motivation of this study, that is look at how legal status has affected access to care before and after the ACA. Why this is a motivation? Well, first of all, because Latinos are overrepresented among undocumented immigrants. Second, because 1 of every 4 undocumented immigrants lives in California. And third, because undocumented immigrants were excluded from the ACA. So the question that we're trying to answer in this paper is, well, how both the legal status and the ACA influence access to care and health insurance coverage before and after the ACA in California. So what we did was identify measures of access to care, use of care, and health insurance coverage in the California Health Interview Survey, that is a state representative population of California. And we did a repeated cross-sectional analysis where we pulled data from 2007 to 2013 of this survey to describe the period before the ACA. And we pulled observations from 2014 and 2016 to describe the period after the ACA. And we did a descriptive analysis, also multivariate analysis to account for socioeconomic differences and demographic factors. And we later implemented a regression-based decomposition analysis where we tried to identify how disparities evolved before and after the ACA between Mexican heritage Latinos and other Latinos. And in this analysis, our main interest was to see how undocumented status acts as access to care barrier between Mexican and other Latinos. The main findings were actually very encouraging because we actually found that there are statistically significant changes in insurance coverage among all the 4 different categories of Latinos that we included in our study. That's U.S. born Latino, U.S. naturalized Latino, legal permanent resident, and undocumented Latinos. Yes, even among the undocumented, there was small increases in health insurance coverage. And the second part of that was very interesting in our research was that most of this increase in coverage was due to public coverage. Because in 2 of the categories that are analyzed in the paper, we actually saw declines in private health insurance coverage among Latinos after the ACA. So that leads us to believe that it was public coverage that was the one who boosted insurance coverage among Latinos. And also, when we actually looked at our disparities analysis, we found statistically significant changes, narrowing disparities between Mexican Latinos and other Latinos in the case of health insurance coverage and usual source of care. When we looked at the role of legal status, we were able to to quantify the magnitude of disparities that are explained by legal status, and we got an estimate that are very robust and statistically significant of 24%. And this is a magnitude that is comparable to that of socioeconomic status and English proficiency. So that gives us an idea of how much of a deterrent of healthcare access and utilization and health insurance coverage legal status remains to be even after the ACA implementation. So what are the policy implications of my work? Well, as we discussed in this paper, there are many useful experiences in California that can be considered in other states. And not all of them are at the state level. Many of these increases that we hypothesize among undocumented immigrants was perhaps by the plans that probably we'll hear later in the next presentation, for example, like Healthy San Francisco, or My Health LA, that are medical homes, but they are perceived as insurance by undocumented immigrants. So there are many opportunities to explore these different efforts at both the state level that expanded medical, also to undocumented young people, but also at the local level that could potentially inspire other states and other state governments and local governments who are interested in investing in expanding coverage to those who remain uninsured, especially in this period when there's so much uncertainty about the ACA and about the future of undocumented immigrants. Thank you very much.
Good afternoon. Ken Jacobs with the UC Berkeley Labor Center. Want to start by acknowledging my co-author, Laurel Lucia, who wasn't able to join us today. I'm going to talk about some of the lessons from San Francisco's universal healthcare programs for states and local governments looking to close the two major remaining gaps to access following implementation of the ACA, access to care for those who do not qualify for programs due to their immigration status, and affordability of premiums and out-of-pocket costs. San Francisco's healthcare security ordinance was originally passed in 2006 under Mayor Gavin Newsom and is now back in the spotlight for that reason. I do want to acknowledge Andy Bindman and Sandra Hernández, who are both here, who played important roles in that creation. So the program has three main components. I think the one people are most familiar with is the Health Access Program, known as Healthy San Francisco. It built on the county's very robust safety net to create a coordinated care system for uninsured workers and residents. It includes primary care homes, specialty care, mental health, emergency, hospital, prescription drugs, and substance abuse treatments. It is not insurance. That means that care is only available within the network and is not available outside of the city's boundaries. Coverage under Healthy San Francisco peaked enrollment at 62,000 residents together with the low-income health program in 2013 and fell to 14,000 in 2016 following implementation. Continues to cover the majority of uninsured city residents, most of whom now are undocumented immigrants. The second main element is an employer spending requirement on firms with 20 or more workers. Currently, it's $2 to $3 an hour, depending on firm size and whether they're for-profit or nonprofit. The vast majority of those funds are spent on health care, or health insurance, or dental or vision, 89%. But some employers choose to pay into the third element of the program, which is the San Francisco or SF City option, which gives workers access to either Healthy San Francisco with discounted fees or to a medical reimbursement account they can use for eligible health expenses. And in its first decade, $260 million in health expenses were reimbursed for 190,000 participants. So it's a sizable amount of funds. In 2016, following implementation of the ACA, the city, a new program was developed known as SF Covered MRA, which provides premium and cost-sharing assistance to low and middle-income workers who have insurance through Covered California, the state's marketplace, and again, that is also done as a medical reimbursement account. The latter program was designed to address the continuing challenge of affordability, even for those who don't qualify for Covered California. So why is that needed? Enrollees in Covered California with high medical costs in a silver plan can still spend 20 to 30% of their incomes on health premiums and out-of-pocket costs. And subsidies in our exchanges, the federal premium tax credits, are based on a percentage of the federal poverty level. So if we take into account higher costs in California, looking at housing costs and other costs, 400% federally, FPL is equivalent to about 500% in California and about 600% in San Francisco when we look at full expenses. And the third thing is looking at high deductibles. Many families lack the liquid assets to cover the deductible costs, especially those enrolled in bronze. So what have we learned from all of this? One, counties can, as noted earlier, the previous speaker, counties can reduce care gaps for undocumented immigrants. San Francisco program provides an important conceptual example of how to transform an existing healthcare infrastructure into a coordinated safety net system that provides universal access to care, regardless of immigration status. And San Francisco is not unique in doing this. 47 of California's 58 counties have programs that provide some access to care for undocumented immigrants, but it varies greatly by county and in terms of both services provided and who is eligible. All of these programs, as noted, cover care only in designated networks within the specific county. So when we start thinking about looking forward, more options are available at the state level. In 2016, as noted earlier, California used state funds to expand comprehensive Medi-Cal coverage for all low-income children, as have 5 other states and the District of Columbia. This last year, we saw bills that would have expanded which undocumented immigrants are eligible for coverage under Medi-Cal. And even if we were to extend Medi-Cal to low-income adults regardless of immigration status, there would still be people above that 138% FPL for whom programs like Healthy San Francisco and the county-based programs would still be needed. Second lesson is addressing affordability is much simpler for states. States, especially those with their own marketplaces, have many more options than counties do for administering subsidies. Reimbursing health expenses through an MRA was the simplest and least administratively burdensome way to do it in San Francisco, but it's cumbersome for participants. And so with greater economies of scale, states could simply pay premium and out-of-pocket subsidies directly to insurers on behalf of eligible people. State marketplaces can also opt to determine eligibility for state subsidies in coordination with the existing ACA eligibility systems. This became a big issue in San Francisco where, because of some of the complications in determining eligibility, it was required to come in person, and as a result, enrollment has been pretty low in the new program. Massachusetts and Vermont have already implemented these types of programs in coordination with their state-based marketplaces, and you can also build on the outreach and education from the state-based marketplace. The third main lesson was that the employer spending requirement is not easily replicable. San Francisco's requirement has worked, and there's an earlier Health Affairs paper assessing that. It's increased access to quality care in the city, and it provides the only source of funding for the San Francisco MRA and SF covered MRA programs, provides less of the share of Healthy San Francisco than it previously did. Any state or local government looking to replicate this, however, would really have to look very closely. San Francisco did withstand a federal legal challenge, a preemption case under ERISA, but anyone trying to replicate it would really need to design it quite carefully. And in terms of local governments looking to do this, it'd be more constrained than San Francisco, because San Francisco as a city and a county had greater legal latitude than would cities or counties trying to act alone. So in conclusion, San Francisco has shown that local governments and state governments can build on the ACA to address these two significant remaining problems, covering those who are not eligible for ACA programs due to their immigration status and addressing affordability. But if we're looking at scaling up what San Francisco did and thinking about what California could do in the future, states have other options to achieve these goals in a way that's more comprehensive and more seamless. Thanks.
So as they're sitting down, Malia called me out for asking why she's on the Access to Services panel. You actually had a better answer than I was going to give.
As to herd immunity.
But I think the theme, and it's always a little bit of more art than science to try to make coherent panels for these events. I think the theme we were trying to capture, and it's what I'll sort of turn to for the group and hope you all will join in with questions, is that financial access doesn't always translate into actual realized services, and that there are a number of different interventions of varying degree, of varying nature, quite variable nature, described in this panel, where you see either a match or potentially a mismatch between those efforts. So that was my not entirely successful effort to give it some coherence. But I guess I do want to ask, as an opening, and it's a little bit of a vague question, but it actually came up with an unnamed reporter who called me and asked me about some of the papers and about the results potentially being disappointing. And I think we heard that word used. What I'd like to get at is sort of the complexity of the delivery system, the time element of change, the multiple actors involved in change, and move us away from sort of a disappointing or a positive negative outcome. And I just wonder if any of you, again, your papers are very different, but I wonder if any of you want to reflect on this notion of the time element and what it takes to take something that has promise at the outset, maybe doesn't show immediately positive results, but what then is used to yield a more positive long-term picture. Again, a general question, but I'm curious if anyone wants to reflect on that in the context of their work.
I'll take it first,
please.
since I was actually the one who used the word
I think
disappointing.
you did. That is correct.
And I would say disappointing in regards to services, but I would, I think, push back a little bit in that I do feel the first purpose of the Affordable Care Act was actually achieved, right? And I think at least my paper shows that, and I think papers before my paper have also shown that, in that those who were insured, a large bulk of my sample who were low-income women who were uninsured actually did realize insurance. In other words, there was this huge shift from being uninsured to being insured through Medi-Cal. And so I would say that my former director at UCSF, the way that she would describe it is you are trying to get people into the house, first of all. So you've now moved all these people into a home, and they have insurance. And now you need to get them actually to the table to eat, right? So they need to get those services. And I think the purpose and the point of my paper that I was trying to make is that we have now shifted all these individuals to having insurance. The next step, now that we've congratulated ourselves that everyone is insured or that a large portion of people are insured, is to actually make sure that individuals are getting access, real access to health care. So they're getting to their doctors, they're getting appointments in timely fashion, they're getting the services they need. And so disappointing in some ways, but positive in others in that these are individuals who would have gone to emergency departments or other safety net programs that now have access to a provider. Let's ensure that they actually have access to a provider.
I'll piggyback on that just a little bit and just add that the Ryan White Integrated Care Clinic didn't grow up overnight. And I think that there was an expectation with Medicaid expansion that somehow we would replicate this really like evolutionary system overnight. And that was not going to happen. Particularly if you think about the kinds of populations that are impacted by HIV, they really do need culturally tailored integrated settings. And there are a number of challenges that are really inherent in meeting individuals living with HIV where they're at. So I think it's not just a matter of getting them into the house and to the table, but also understanding what kind of things that they want to have on the menu and bringing the people in who can actually prepare those meals the way that they would want to consume them. And so I think that we need to do more work refining the healthcare delivery system as it is. I would say I think it has a lot of promise, and from the perspective of people living with HIV, gaining access to Medi-Cal was a huge relief. Someone said to me, okay, well, before I had coverage for HIV, but if I walked across the street and got hit by a bus, I would be wiped out. So this is what Medi-Cal has given me. It's this security, knowing that I can get services.
The metaphors are proof that this is a pre-lunch panel.
That's good. I liked it.
What's in those lunch boxes?
Right. Any other reflections on this, or I'm happy to turn to the audience. A lot of very different papers, so please, let's get some questions. If you can wait for the microphone. It's coming. No, it's coming right your way.
Hi, I'm Barbara Turner. I'm a general internist and health services researcher at USC. And without being too self-serving, I think a lot of the issues have to do with primary care and access here in California, but also nationally. But I was going to ask Dr. Muench if the nurse practitioners that you were looking at were going into primary care, because in my experience, a lot of them are going into specialty care.
Yeah, that's a really good point that you're bringing up. And for our study, we really focused on primary care, so we made sure that, thank you, that these nurse practitioners were working for the majority of their service in primary care.
Right here. Jamie.
Thanks. My question is for Malia. I wondered if you had suggestions or thoughts about for states that can't implement laws like SB 2177, if there are options to address the school clustering, if there are programs or policies that you think would be well used and good suggestions for those states to kind of get at that phenomenon. Thanks.
So I think that that's really the core of what needs to be developed is policy solutions. That, policy has been our most effective tool at getting kids vaccinated and achieving high herd immunity rates. And we don't have a good policy solution to address this issue of clustering. And that is really, I think that's sort of the main outcome of our study is that, to respond to the disappointing theme at the same time, the results of AB 2109 were disappointing in some ways, but they were not unexpected. We knew that there was this school clustering, and we also know that parents who don't want to vaccinate their kids hold these beliefs quite strongly. And also, we're talking about 5-year-olds. The vaccine series starts at birth. So they have been having a conversation with the healthcare provider all along. And getting that signature on a form was just not a big hurdle for a lot of the parents who obtain an exemption under AB 2109. And yeah, so I think that one of the key outcomes here is that, in the absence of a ban on exemptions like the new California law, what can we do to deal with this clustering that we know exists? And I think one of the things that we could do is really try to understand how do vaccines not meet the needs and desires of parents right now, and try to sort of reframe the way vaccines are viewed by parents who are resistant and improve their uptake.
Arturo, I'm going to ask you about the improvements in public coverage, which I think surprised some people. So can you just go a little deeper into that result?
Yes. In every single of the categories that I was investigating in this research, most of the gains in insurance were due to public insurance. And obviously, since the undocumented were excluded from the ACA, what can we expect them to be saying, well, it was because of public insurance? So what we attributed it was to the perception that they were having insurance through medical homes that are not necessarily insurance, such as Healthy San Francisco or My Health LA, or even integrated community clinic environments where they perceive it to be insurance, even though it's only integrated medical care. So in that sense, I think that's a little bit of perception from the undocumented community. But in the case of other categories within the analysis, like legal permanent residents and U.S.-born citizens and U.S. naturalized citizens, I think it's primarily because of the income thresholds made them eligible to have medical instead of having private insurance. So as it's discussed in the paper, it's also a possibility that there was a little bit of crowd out of private insurance because they probably left private plans that were less comprehensive than medical, and they moved into medical because they became eligible after the ACA.
Yes.
Good afternoon. Great conference. I'm Patrick Dowling. I'm the chair of family medicine at UCLA. This is for Arturo, maybe a gentleman from UCSF. As you know, there's a concept called the public charge and mixed status families. Public charge is a belief that if you incur public services, you will impact your eligibility to become a citizen later on. And mixed status families are families that one parent is citizen, the other is not. And many thought their kids were not eligible because of this. When Pete Wilson was governor, there was dog whistling going on, as we said, and it really cut the enrollment in Medi-Cal at the time. Given what has happened in the presidential leadership here with all the charges against Mexicans, what impact, if any, do you think that has? There'll be a large health fair coming up here in about 3 weeks in Los Angeles called Care Harbor. You'll see about 2,000 to 3,000 people, and the number of families that show up that are eligible for Medi-Cal but are afraid to go is still a problem. Do you think that's part of what you're seeing? Is that true in San Francisco as well?
So you want to first? All right. So yeah, I think it's a very legitimate concern that this adverse immigration climate that we're experiencing right now, and also the animosity against the ACA, is like confounds like these fears in immigrant communities, especially those who are in mixed status families, where like children could be potentially enrolled in this type of plans. Also, for example, among the DACA population, who they will say, well, I gave all my information to the federal government, and now I shouldn't be doing that. So among this population that are on a day-to-day basis very fearful of institutions finding out about what they are doing, I see a legitimate concern about it. And I think that the state should be, it has been emphatic about saying, we are not going to do anything against you. We're not going to share this information with the federal government. But I think that definitely more should be done in order for them to actually believe that there's a difference between the state government and the federal government. And the state government is definitely, as up to now, like trying to protect them from outside intrusion.
Yeah, I just said we're hearing a lot of this from community groups and from providers. And there's a number of researchers out there now who are trying to look at this in more depth. But yes, it's a concern overall, both for will people use the health access programs and have fear there, or as you've mentioned, for mixed status families, do I enroll my child in a program where that could then come back and affect my immigration status later? I think it's a very serious issue.
I think it's the stomach rumbling that's happening. Okay. Don't stand up, but please, first of all, join me in thanking our service pioneers. So we typically end these before lunch, but we have so much content we wanted to get through. What we're doing is we've got box lunches, a relatively short break, and then we'll come back for our final panel, which will be more forward-looking. If someone, I assume lunches are right outside, and they can be brought back in. So we're going to give you 15 minutes to go get all your talking out. Come back at 25 till, and we'll start up our closing panel. Thank you. We are ready to wrap up our half day here. We decided to make the last session a little bit more conversational, hopefully keep you awake. And let me introduce, if you do not know, Walter Zelman, Professor, Chair of the Department of Public Health at Cal State University, Los Angeles. I'll do these in order. There was no order. Ninez. Ninez Ponce, Health Economist, Director of the Center for Health Policy Research and Professor at the UCLA Fielding School of Public Health, Department of Health Policy and Management. Andy Bindman, already noted, Theme Issue Advisor, Professor of Medicine, Epidemiology and Biostatistics, and core faculty at the Philip Lee Institute for Health Policy Studies at UCSF. Lucien Wulsin, founder and retired executive director of ITUP, the Insure the Uninsured Project. Paul Hsu, senior researcher at the Southern California Injury Prevention Research Center, assistant adjunct professor in epidemiology at UCLA School of Public Health. So, our topic is looking ahead, and the papers, which are not going to be presented precisely as papers, looked backwards and some thinking forward on two central issues that define California's position and activity as a leading state. One is around multiple efforts to expand health insurance coverage, including periodic efforts to achieve universal or near universal coverage, as well as focus on health disparities, health equity, and leading the nation in some of the demographic trends that are emerging around the entire country. And so there's additional experience here that may be instructive for the rest of the country. So I've set up a set of quick teaser questions just to get the conversation started. I am hopeful you all will interact with each other and not just back and forth with me, but do let each other get a couple of sentences in. So let's start with Walter. In your paper, you trace a long history of efforts to expand insurance coverage in California. One of the things you say is that much can be learned from the failure of those efforts, and so perhaps you can tell us a little bit about what can be learned from those failures.
Well, first, thank you, Alan, for giving us two great challenges, 3 minutes and no slides. To which I'm going to go for the trifecta, no empirical data whatsoever. But let's start with the demographics of failure. Whatever measures you look at in a state like California, you come up with a large number of uninsured Americans or individuals. It's small employer dominated. You have an hourglass economy that has many wealthy individuals, but also very many low-income residents. We have a large low-wage agricultural sector, a large number of recent immigrants, many of whom remain undocumented, a modest level of union penetration, especially when compared to states in the East or in the upper Midwest. For coverage expansions, trying to understand why you might succeed or fail, these demographics outline some pretty harsh political and economic equations. No matter how great the effort to achieve coverage expansions, no matter how creative they might be, you're still looking at a very uphill climb, and the obstacles are massive, the financial obstacles especially. Compounding these demographics, California, those of you who are native here, know about the two-thirds vote increases we have, the Jarvis-Gann initiatives from 40 years ago, limit the capacity to tax, limit the capacity to spend money, and all these things, as we look back on it, constantly we're forcing advocates of universal coverage to adapt various proposals and create these convoluted strategies of having to pass legislation in the legislature and then having to go to the ballot and win there as well, the California or Los Angeles equivalent of having to beat Clayton Kershaw twice in a week. Powerful forces were ever present. Chambers of commerce, large and small, the insurance industry, big agriculture, sometimes powerful interests in the provider community, and the only potential or actual financial counterweights to these forces were sometimes physicians and labor, which was often split between single payer and other goals. In recent decades, if you think about political leadership, another critical factor in this equation, with the exception of Schwarzenegger in 2007 and 8, Democratic legislators led most of the efforts for coverage expansions. Republicans opposed across the board. But executive leadership counts. And if you think back on Jerry Brown's 16 years and Gray Davis's, 5 or 6 years, very little leadership on this issue. They never put it high on the agenda. But in spite of these obstacles, California produced a lot of innovative ideas, a lot of incremental success. Those things worked their ways into the national discussion. They worked their way into the Clinton plan. They worked their way into the Obamacare plan. And eventually, I would say, and we agree, California got what it needed, basically money. The money it could not produce by itself to afford expansions through the ACA. Finally, a word on putting this in history and what it tells us about large progressive efforts to create change in America or in California. If you think back to the 1960s, and many of us, I'm looking around, can do that, the Johnson administration spearheaded a whole series of major policy breakthroughs, a whole wave. Medicare, Medicaid, immigration reform, anti-poverty legislation, the Voting Rights Act. This wave was facilitated by a host of factors coming together. Pent-up demand, a strong economy, solid legislative majorities in both houses, a supreme political and legislative strategist able to twist any arm in sight, and an assassinated president to build on, and a massive electoral victory in 1964. California never got anywhere near that set of circumstances. And that may be what it takes to create a real wave of major change. So think about it as a way of thinking about it. Here we are at Rand, near the California beaches, and I would offer us all this advice about creating great change in America. In order to create great change in California or America, you need at least three things. The right, almost perfect wave that has to come along. You have to be in position to catch it. And once you catch it, you have to know how to ride it.
Right. All right. Now I know why you wanted to speak from the lecture. That was wonderful, truly. You wrote the paper with Lucien. Lucien, in the paper, you also say that stakeholder opposition matters. And yet, here you are with significant incremental expansions of coverage despite not being able to complete the deal when it comes to universal coverage. So if stakeholder opposition matters, how does that translate into this long-standing series of successful incremental expansions?
Well, I want to start by agreeing with Walter that dollars was the key. But let's just take a look at two ways of going. And the one way is let's do a single payer. And then the other is let's do incrementally improve covered California, expand Medicaid. So we head off for single payer. And what we find in our opposition from the start is the hospital association, the medical association, the insurers, the Chamber of Commerce. You know, it's a pretty daunting crew. And from Andy's work, it may cost us close to $200 billion, which is about what California's budget is. So it's a challenge to bring all the private money and translate that into taxes, and then have the hospitals and the doctors and the insurers saying, this isn't such a great idea. On the other hand, we say, all right, let's improve covered California in some of the ways the legislature is talking about. Let's put it up to 600% of federal poverty level. Let's maybe tie it to a stronger thing like a gold coverage instead of silver, so that people get much better access to services that way. At that point, you flip the hospital association, you flip the insurers, and you flip the physician groups, and you've suddenly got a much stronger coalition pushing for coverage. And that costs maybe $600 million or so. So I mean, the magnitudes are. But when you think about our choices, we did incrementalism in California. We did pregnant women, we did kids, we did breast cancer and everything else. And what you would see is you'd expand, and then right out the other end, you would be losing employer coverage because costs kept going up and the employer coverage keeps going down. So every year I'd look at Rick Brown's wonderful reports and I'd say, boy, something has to be really good now. We got something done. And every year he'd say, things are getting worse. More and more people are uninsured. So I think those are the challenges as you try to put something together. Incrementalism is the more doable political strategy. It has some strong building blocks on the ACA, and that's probably the way we want to go. But getting a whole system that works together is a desirable outcome, and the question is, how can you do that without facing a huge tax bill and a lot of controversy?
So let me follow up the two of you, and Andy, I'll bring you in a minute unless you want to jump in on this. I mean, when I think nationally, you talk about expanding Medicaid, you talk about expanding the exchanges. You, Lucien, describe that as something that providers would like in contrast to single payer. In most of the world, those are low payers relative to the commercial market. We just had some data presented about cost growth, and there wouldn't be so much enthusiasm about taking public programs up to 600% of poverty because the payment rates would likely be more like Medi-Cal than commercial or somewhere in the middle. So I'm curious, coming in from the outside. Is there really that much willingness on the part of the delivery system to support incremental expansions with the understanding that the rates may be more like public rates than private rates? Not that you're to speak for them.
But you've got volume. Sorry.
You make it up in you make up
but
your
you've
losses.
got volume. If you've got 13 million Californians on Medi-Cal, you've got volume. And then, Kaiser started expanding with Medi-Cal programs. So that's.
So you're saying yes, that once it's that.
I think once you've got enough people that are on public programs, that you're going to get the attention of the commercial sector.
And also, we've been changing Medi-Cal over this same time frame, and so Medi-Cal is a very, very different program than it was 20 years ago. There's a lot more managed care. Hospitals have been able to get some, more favorable reimbursement rates, and so yes, Medi-Cal does have some problems with provider participation and perception, but it has a strong building block in California, I think.
So Andy, I want to bring you in. Your paper really based on the work going on now about looking at options for universal coverage, and Lucien, you sort of teed it up this way. There's single payer, and then there's kind of everything else, incremental this plus incremental that plus incremental that, and it adds up to something. But it's not as disruptive as single payer. So is that the dividing line in California, or is it that feels? Give us some nuance to that dividing line. Put it that way.
Well, I'll first just a little bit of context, which is, our state is in the vicinity of about 93% covered, right? And that's a huge improvement from where we were prior to the ACA. And of those who remain uninsured, more than half are undocumented adults. So that's a big chunk of it. And as you know, the ACA really didn't provide a solution for that group of individuals. So to some extent, that's understandable. And it's also, for important reasons that were raised here today, it's very important in our state because we're a very diverse state and we do have a lot of individuals. We've also taken some steps, as was described. We now cover undocumented children, for example, through the Medi-Cal program. So this is space that we're familiar with. I do think that also, just to give you a sense of the scale, some numbers were thrown out in Walter's excellent presentation, but the size of the healthcare nut, if you will, in California, about $400 billion this past year, right? That's a big number, where there is the discussion around the single payer stuff of could you put all of that into one pool and start to become a more efficient purchaser and do more than is going on with the fragmented approach, and I'll come back to that in a moment. I do think that when you're at 93%, you can start to see the light at the end of the tunnel. And that does make you, if any of you are runners, when you see the finish line, the adrenaline gets up a little bit and you're excited to run to the end. And I do think that there's something very attractive about the idea of thinking it's not that big a gap anymore, maybe we can get there. And, when you start to see various price tags associated with that, while it's significant to be able to cover additional individuals, you're still talking in the billions, but it's probably in the handful of billions as opposed, in the context of a very wealthy state, it starts to become quite achievable. So I do think that if your goal was mostly about how do we get to 100% coverage, it does feel perhaps easier to reach between, just growing on the chassis of ACA to get to 100. Having said that, I think there is also a very strong feeling among many of the stakeholders, as your question raises, which is not only do we want universal coverage, we want to get rid of the dark side. And I do think that many people have strong feelings about the healthcare industry and health insurers in particular, and the value that they're bringing to the environment. And so for some individuals, it's not just about universal coverage, but this discussion is also about eliminating a part of the industry or taking that on. And so there is a lot of discussion and philosophy around how to handle that. I do think that there are, as was brought out through some assembly hearings this past year in the state, not only could you get to universal coverage potentially through a single payer approach, but you could talk about unified public financing, which is the idea of bringing together and collecting the money together in one pool, but still potentially using health plans as intermediaries. And the comparison that's often used is the Medicare program, where the money is collected in a similar way across the population through payroll tax and contributions of beneficiaries, but that individuals can either stay in the single payer program, which is the Medicare fee-for-service program, or elect to go into Medicare Advantage and use health plans. And in fact, we're seeing an increasing number of people across the country doing that. And here in California, over 40% of Medicare beneficiaries are in Medicare Advantage plans. So there may be some kinds of in-between strategies like that. But I do think that the point is that there is probably a little bit of a debate going on about whether the main problem we're trying to solve is universal coverage, which is terrific in terms of helping us with some of the access issues, but maybe is not the strongest way to get at some of the price issues and the cost issues in our healthcare system that were talked about earlier today. And maybe to do that, we needed to bring about this larger set of changes. And I think part of the place that we're at in terms of the fork of the road is whether we are trying to bite all of that right now, or whether, again, an incremental strategy of first get everyone under the tent, and then we'll do that second part. And I think we're still sorting that out among the stakeholders about how they feel about that.
Can I just comment on something you said, or do you want to?
Yes, no, please go ahead and comment.
First of all, I don't want us to get confused about the terminology. We shouldn't be talking about single payer or incremental. The ACA is not incremental. It's about as big as American policy gets. It is a huge change. California's now at 77% uninsured. I said I wouldn't use numbers, but 7% uninsured, 60% of whom are undocumented. So California's gone an awful long way. You probably try to squeeze universal coverage and get hung up on can we get to 100, maybe missing the boat. But I think our first challenge, short-term versus long-term, is preserve the ACA. Whether we build on it or move, and I think you can move the ACA more towards a single-payer type thing if people will get out of their silos. You could move from ACA to expand it towards single-payer type concepts without throwing the baby out with the bathwater, which I think would be really a dangerous step to take.
So before we get deep, that's a good point, and before we get deeper into that, I want to, one of the things, again, coming in from the outside that I wanted to try to make some sense of here is, Andy, you just asked, it depends what the main problem is. Is it universal coverage? And you didn't give the second, but it's basically, is it broader health system change that a single payer model could achieve? But there is a third potential problem to solve, which is the huge health disparities in the state, which is also tied, of course, to the others. But what I've been trying to understand is it's very, I want to say easy, but it's very traditional to come at sort of the universal coverage discussion from the finance organization side. But we had, and you all are familiar with it, we had additional evidence presented today on differential rates of maternal mortality, the documentation status of the remaining uninsured. It seems basically impossible to think about the future of universal coverage without thinking about the health disparities in the state. And so what I was hoping we could try to do is to not have a disparities conversation and a single payer conversation, but see how to bring those together. Ninez, I know we were going to try to get your slide up. I don't know if it actually got there. I gave Ninez a special exception.
Yeah.
Yes. I have a lot of power in this job. So the special exception is that despite it being a panel, because her data are in the form of a map, and it's really hard to speak a map, why don't you present a little bit on on the disparities data in your paper, and then I want to talk about how to bring that into the universal coverage discussion.
Great, thank you for the exception, Alan. I also just want to, first of all, call out, we were about a 5-piece band that got this paper out. The lead singer is actually here. The lead vocalist is Carrie Sanders, and the lead guitarist is the wonderful Michelle Coe from UC Davis. And I think I was just backup and maybe managing the band. So this is a map that gets at the diversity. It uses a diversity index. And for those of you who work on disparities and then looking at regional and within, how mind-boggling it is to try to look at like a 4-dimension of disparities and across space and time. And so what this does is it's a summary statistic on diversity, which is basically what's the probability, what's the chance that you're going to run into somebody in that region that's of a different race ethnicity as you. And so the darker the map, the higher the diversity index. So you're seeing that it's not, it's no surprise that the Bay Area it has the highest diversity index, and then some areas in the South. So the urban areas do. But what we also did was superimpose what the plurality was, because it's not just that it's a diverse place, but what racial ethnic group would be the most common in that area. And so we have an L for Latino and a W for whites, and it's basically Latino is in whites plurality, except for Santa Clara County, where Asians are a plurality. And then later on, then in the paper, we look at then how this play out in terms of differences by race, ethnicity, and then by different regions. And we can talk to Richard Scheffler of, are the 19 rating regions for covered California, is that a good marketplace? But we looked at it that way. And we then saw that where there was the greatest disparity, we're in those areas that's actually highly diverse, like diabetes, there's this great disparity, say, in the Bay Area. But the lower disparities, though, that's not enough for a report card, because the lowest disparities, though, would be in the rural areas, but then overall, say, the quality of care and the health would be at a lower level. So again, this is like among those of you who've looked at disparities, you kind of get at, you're trying to solve several problems. You're trying to get everybody at a high quality of care. You're trying to reduce disparities. But if you're just looking at disparities, then you want to make sure that that quality of care has to be at a higher level. So that's, I think, a summary of that map.
Right. That's terrific. And if you can't see the letters, look at the paper in the journal, and because it's the combination of the shading and the letters that present the data. So let's go then for the implications. And in the paper, you talk about managing diversity to reduce disparities, and that's a term or a phrase. Just give that phrase some meaning.
Okay, so first I also want to call out, if David Hayes-Bautista is here, I think he called that out.
Yep.
Called that out about 9 months ago, and I think it's the managing diversity requires a framework of health equity. I think that's kind of the simplest way to put it. And to get that framework, you need to have the commitment of the leaders in the healthcare system as well as the payers. You need to have the data to drive the change. I was very delighted that I saw some California Health Interview Survey data here. But we also use data from California Regional Healthcare Cost and Quality Atlas, which very important in terms of the system accountability. You need to have advocates, and I think that's, I was again hearing today that this community engagement was very important, a really important ingredient in affecting change. And so advocacy is really important, and not just at the state level, but at the local level. And then, it comes back to money. So you need the financing mechanism to affect the change. So one of our examples was the revenue from cap and trade that focuses, from the greenhouse emissions. And so it focuses that money on disadvantaged communities in California. We also think that we talked about language access, which was, gosh, I think I started my career at UCLA on that back in 2003 when there was like first ever language access among the commercial insurers, and requiring that you have language bridging services. But so that was the first, but were limited English proficient patients really doing better and not? This was 15 years ago. And so now there is, well, maybe we have to pay for reimbursement services. So I think that that becomes the issue, that the financing is really important. And sorry, the last one is accountability. You have to have the metrics for accountability.
Paul, I want to bring you into the conversation. We've gone a long way without getting to you, and I want to make sure the road brings you in as well. So again, in your paper, you present the notion that diversity can be viewed as a strength for achieving better health, and that, again, much of the discussion around disparities and inequities treats it as sort of a negative or a risk factor for achieving good health. So say a little more about that.
Yes, thank you. Let me, if you don't mind, give a little bit of context first. I think for a long time the narrative was that, as you mentioned, diversity leads to negative health outcomes. And even the construct of race itself was tied to a biological construct, genetics. And I think now and I think I'm speaking to the choir here, it's more of a social construct, and it might even be a proxy for, income, education, and other social economic factors. But, and so when California, as we've mentioned in our work, was 20-some% minority, and now it's 60+ in the last 40 years, there was a narrative out there that this would lead to, California is going to become a third world country or nation or whatever, and that has not happened. And we point to data that show that, in fact, California is doing really well. And so I think we first wanted to say, part of this new narrative, and we had even a discussion among the authors, the co-authors, about using the term alternative narrative, because the connotations nowadays about alternative facts. But a new or different narrative that there are positive factors to diversity. So we're trying to call this new narrative the epidemiology of diversity. And it's an invitation and a challenge to this group. We actually don't understand how it's all working either, but the data are showing that there are really positive outcomes. And if I just may address, I think, Elliott, are you still here? Earlier, he showed the maternal quality care, and you saw the really striking differences between some of the groups. But he also mentioned, and I wanted to kind of highlight that, the positive part, there were other groups who had the same or similar social determinants who had positive outcomes. And we still don't know, completely understand how or why that works. So if we can identify those and apply those, I think that would be such a positive outcome. And then just one last quick thing, it's Ninez and I actually didn't talk at all before the paper, but I was really, it was great to see that we came up with a lot of the same things. She mentioned leadership at the state level. She mentioned partnerships, coalition building, and we actually mentioned the same group, which is PEHN, the Pan-Ethnic Health Network. CPAN, California.
Yeah.
Thank you. And that actually includes both the African American, the Latino, and the Asian communities.
And American Indian Alaskan.
And American,
too.
thank you. So we both mentioned that without any, crosstalk before. So I think those are some of the things, coming back to what's been mentioned, which is community agency, community engagement, and coalition building, I think can really point the way forward.
So this is my question, is can we make this one conversation instead of two? And so what I heard this morning was the best outcomes occur through initiatives that engage communities, patients. I just heard that California is doing better than the old diversity narrative would have suggested because of strength of community, that once there's the map's not there anymore, but it's all right, we don't need it. But, you know, once there is, if you will, a critical mass of communities and there's some empowerment, that can then lead to institutions that help overcome some of the disadvantages that might have otherwise existed. But then I hear this provider-led, labor, money discussion about universal coverage, and it's like a totally different vocabulary. And my question is there anything that brings these two together?
If I could just,
maybe.
Go ahead, please.
No, go ahead.
If I could just jump in very briefly, we're seeing that, and if I could just acknowledge some of our co-authors. This was definitely a teamwork effort. Theo Garcia Maria and Mara Bryan, who's not here, from White Memorial, and Dr. David Batista again, and K.O. Shaparlo from Charles Drew. They're seeing that already at the local level at White, which is a community-based hospital. I don't remember the number, 60, 80% of the patients are Latinos? Pretty high. So, you know, they're seeing 90. So, you know, they're seeing that already at the local level, and they've put programs and other things in place to try to work, you know, to address that population. And I think knowing ahead of time that this is not necessarily going to be a negative outcome, knowing that this has an absolute potential to be a positive outcome, I think will help that.
I would say if there's a bridge between the two, and this may be a little on the naive side, if there's a bridge between the two, it may be public health. Because public health is more community-based, more population-based, and long-term based. Private insurance, with which I'm having more and more reservations as I grow older and older. Private insurance is more individual-based and short-term-based. And it seems to me those two things are oil and water. It's getting harder and harder for me to see how an insurance-based system in which profit is made not always by doing the best thing can really drive quality and lower cost into the system. So on the other hand, public health, nobody gets it. We don't understand it. We need to explain it to people. And Americans think individually. As we all think, when we think about healthcare, what do we think about first? Ourselves, our families, our kids, right? We don't think about, oh, I care about this community. No, that does not seem the road to better healthcare to most people, and yet in the long term, it probably is, or at least more emphasis there relative to emphasis on individual breakthroughs, you know, in the new clinical science that the next hospital can deliver. So maybe public health is something of a bridge between this community-based thing and what we have.
Well, I was just going to say, I mean, I think what you're putting your finger on is part of the complexity that comes with a multi-payer fragmented system that is functioning under very different rules. I mean, we even heard that, you know, even if you take the private side, you've got like the ERISA plans versus the ones that are, you know, fully insured plans that function. You know, the rules are so different, it's very hard to create that kind of coordination where if you were trying to empower communities, you could even have a common set of messages across the different payers to get, you know, working toward a common set of goals. And I think what we've really struggled with, we have incredibly powerful and interesting stakeholder groups working at community levels and so forth, but we struggle with that kind of coordination that I think you're speaking to that would allow us to move toward these larger, you know, social goals, because the rules are so different. And I think just from a pragmatic or a kind of a strategic point of view, again, the question is, do we take that on as our first thing, to take on the fragmentation and make our performance better, or do we first, as was kind of alluded to in the before lunch panel, get everyone into the house or get everyone under the tent so that everyone understands, okay, the first set of rules is everyone gets some form of coverage. You know, the second rule is how do we now use our resources efficiently, and what are we trying to do with that? And I think that's partly a strategic thing to think about, whether we, again, go for all of that at once versus getting everyone in. And I also fall back on a comment that I think you made in an earlier panel, Alan, which to sort of say, look, some of these, when you're first getting everyone under the tent, of course it's going to take a while to kind of build those kinds of infrastructure. So I do think that there's something to be said for getting people under the tent, and that's where maybe, in fact, there's a bridge between some of these short-term strategies that are being talked about of saying, all right, if we first, as a state, decide, no, we really do mean to include everyone who lives here, not just those who have, were born on this physical soil, but people who reside here. Let's get everyone in. That's a value that we share in the state. And now we're going to work toward how to make our system work better. And maybe there are some tools that can work in our multi-payer system, but I think we're all recognizing that when you look around the globe, that although there are examples of multi-payer systems, they're much more regulated about figuring out how you standardize what those insurance products look like when you move across them. I mean, part of the complexity we have here is if you're in Medicaid one day and you're in commercial insurance another day, or Covered California, that you're not just changing plans and who your provider is, but what your co-payment is, what the formulary is. I mean, everything changes at once. And somehow we think that that's supposed to result in a very smooth-looking machine. And of course, it's crazy. I mean, it takes so long to kind of figure that out. So that is something that absolutely needs to be fixed. But the question is, how do we sequence that? Does it first get everyone included and then do it, or do we fix that at the same time? And it's, that's a strategy question that needs to be addressed.
So I'm going to jump in. Aside from you, also have the unique in the country of having two different regulatory agencies over health insurance. So it's even more than that.
Yeah.
But two thoughts. I mean, just from a national perspective, I will say there's a lot of energy going on around the country in the belief that because we probably will never do as much public health as would be warranted by the evidence, all of these payment incentive programs, you can call them what you will, some is accountable care organizations, but that's, the various pay for performance are all about trying to leverage the dollars within the insurance system to move those investments. The only other data point I'd add is that having been involved in the Massachusetts universal coverage efforts, it's very clear that they made the bet that they would do coverage first and work on the system second. And partly the politics of coverage, when you have the money, are better.
Yep.
You're not, and also the sense that if everyone's in, you've got better odds of improvement than if you try to improve with people falling by the wayside. So that's at least one place that this has happened. I'm going to do Lucien and then Ninez, and let's keep going.
I was struck by the first panel and the important things that were being done regionally and statewide, because people kind of rolled up their sleeves and just, kind of got to work. And I mean, I would just think that if you combine the data and you get a lot more transparency in the system and you give a lot more leverage at the local level to try to get people who want to work together to actually work together, we're a lot closer to really beginning to focus on outcomes than we maybe give ourselves credit for, because we do have so many folks in managed care, and some of them work, reasonably well. Others maybe not so much, but we've got a lot of infrastructure in place, and it's a question of, really driving the outcomes using the infrastructure that we have.
So I think you have to do both, because you can't just, I'm terrible with idioms because I'm an immigrant. You can't, I get it, totally good. You can't wait for that wave to ride it. So I think you have to do both. And as a health services researcher, disparities researcher, variation is good because you can compare. So one reason why what we also saw was, no surprise, folks that are on commercial insurance do a lot better in a lot of the quality standards. So you want to have that anchor of aspirational of what it should be. So I think if you don't have, if you don't do anything now with quality of care and then just wait for everybody to get into the tent, which I think you should do at the same time, then it's going to be harder to solve problems, because there's always, of course, going to be, with the newly eligible populations, there's compositional difference. They're a different type of group that's going to come, and you've got to be ready to help with the navigation and taking care of that population. You can't just wait until everybody's under the tent.
I had one concluding thought, which I mentioned to you earlier. I would encourage all of the, thinking about these problems, I would encourage all of the professors out here and the academics out here to encourage some of your students to start thinking not just about however marvelous all the research we saw presented here was, to start thinking about how do you actually get from here to there. And it is a political universe out there. It's a policy universe. And it's incredibly challenging. And one way to think about healthcare more positively than we have been often is to try to think of some other large, huge enterprise that we do better. Education, public transportation. Even the military is pretty wasteful, right? It's very hard to think of you take something this big, this complicated, if you do it 70% well, you're doing pretty good, I think. You might fail in the college class, but that's pretty good. So again, I think the most immediate challenge when you think about healthcare today is don't let the ACA slip away. And that could happen very easily if we're not very careful. So all go out and vote. But other than that...
And preserve the rights
I just
that we
think
have right now.
so I would encourage some of you in the academic world, get your people to think about politics and policy. Research and politics doesn't always go together. Researchers tend to be slightly different than politicians. And I don't mean elected politicians. I mean people advocating, caring about the issues, and wanting to make the change rather than understand what it should be. We need a few more of those people.
I just think we have to be careful that we don't think 70% is good, because when we had 83% covered, if we'd stopped there, we wouldn't now have 93% covered. So got it.
Overall, big picture.
Overall, big picture.
But imagine perfection, 70% may be pretty good.
Andy, I'm going to ask you to say one last thing, and then I'm going to close. But you were our theme advisor. You got to see a lot of papers, and I just wonder if there's something you'd like to put together here from your
Well, well, thank you. First of all, it was a real honor to work with you, Alan, and your team. I mean, what a tremendous organization Health Affairs is, and to do this for the state of California is really a gift to us. So thank you to the foundations that contributed to this and had the foresight to do it. It sort of picks up on what you were saying, Walter, which is you are encouraging the researchers. We're so lucky to have an environment here in California of having foundations that are helping us to think ahead to our future. And so really these are incredibly important structures in our environment, and we're really fortunate to have them. But I guess I think we're at a kind of an interesting crossroads in the state, and some of these themes worked in and out of the different papers, in which we sort of have to make some choice about whether we are going to try to see if there's a way we can bring competition back into our state in a way that's going to work, whether we're at the point in which competition is kind of like, I think we missed that boat and we have to move to more of a regulatory strategy, or even go a step further and say it's time to say that it's a public entity. And I do think that it's the conversation has picked up in terms of where we are with regard to that. And something we didn't say here, but I think is very much on the minds of folks, is you can't underestimate the degree to which there's some reaction within the state to what is going on outside of the state, right? That very much California has positioned itself as part of a resistance or a reaction to what it has seen going on at the federal level, partly to preserve what's gone on, but also because there's an overlap of these issues. It's not just healthcare. It is also about immigration policy. It's about climate change policies, a variety of policies that are coming into play that are activating people in a different way. I mean, any of you who have children who are now of voting age, I mean, it's kind of exciting for me personally to see the degree to which my children are extremely interested in politics in a way that gives me hope about where we might head up. But I do think that we are coming to a very important fork in the road to figure out whether we can, and I think we saw representation of different points of view a little about this in the issue, about whether, well, did we just not, did we not do good enough job of making sure we had competition, or is that so far out of the gate that now we've got to move to more of a regulatory process, or even, as we're talking about with single payer, move to a public system? So I do think we're at an important fork in that road. It's not unique to California, but we are very lucky to have a very robust community of investigators who is making us aware of this issue. And I do think the politics, in a way, the wave that, Walter, you referred to, is coming. And then the question is whether we're going to have the skills to ride it and to take advantage of it. And I guess also sometimes when people ride it, they try to do too many tricks and they fall off the board. So hopefully we'll do just enough tricks to look good on TV and bring about the changes we needed. But anyway, thank you.
So before I thank the panel, just a couple of closing words. I too want to thank the California Healthcare Foundation, the Blue Shield of California Foundation, the Scheffler Center at USC, and the California Endowment. It does take a lot to make this happen. I want to say that although I think the politics are important, and they will always be important, we, of course, view our role as bringing the evidence that helps those who are advocating for policy, regardless of their point of view, to have a solid evidence base for that. And as we close today, I'll just note that the metaphor before lunch was about food. It's only appropriate the metaphor now is about surfing. So with that, it's only 1:30 in the afternoon. And Ocean's only a few blocks away. Thank you for joining us today.